Hello, my name is David Myers. I'm the chairman of the Facial Pain Association, and on behalf of our very diligent staff and 85 volunteers, I welcome you to the first FPA Virtual Conference. One of the great things about having a virtual conference is we have people attending today from almost every state in the U.S. and many, many countries around the world. Welcome to all of you. I'd like to share with you that the first FPA conference I went to was about 10 years ago, Richmond, Virginia. It was a watershed event in my life for two reasons. One is I learned so much. I had a better understanding of the alternatives and the important healthcare decisions I'd have to make going forward, what the right path was for me. I learned a great deal of information. I got insights and wisdom, and I hope that you benefit from all of that today too, so you also will be in a better position to make these very important decisions. The other reason I loved that conference was there was a room full of people, lots and lots of people, and I felt part of a community. And you know, this can be an isolating event or a condition, and so that was very helpful to me. That's a lot harder to do in a virtual conference. In fact, I'm sitting in my office right now, home office, nobody's here. You might find yourself in a similar case in a room all by yourself. But I want to assure you, you are not by yourself. You are not alone. We have about 35,000 people associated with the FPA. We have a wonderful medical advisory board. We have 85 volunteers and a staff. If you have questions, you want to be connected to one of our mission is to provide information, and please don't ever feel alone. Call us, email us. We want to hear from you. Now, this has been a tough year for most all of us, but we at the FPA have had a very good year. Even the last 4 weeks, I'd say it's been extraordinary, and that's good for you because we're here to serve you. Today is our first virtual conference, and by the way, this really is our first one, and so if there's a hiccup throughout the day, please just forgive us and we'll be better next time. The other thing that's so extraordinary about the last month is we published our book called Facial Pain, a 21st Century Guide for People with Trigeminal Neuropathic Pain. Hey, that's you and that's me. This is 3 years in the making. It was both authored and co-edited by Dr. Jeffrey Brown, who I'll introduce you to in just a moment, and Ann Simnecki, one of our board members. It's an outstanding book. I've been asked to tell you that if you want this book now, you need to go to the FPA website to get it. After the first of the year, we hope to have it on Amazon.com and other internet booksellers. But if you want this great book right now, you go to the FPA website. A number of important thank yous are in order. First, I would like to thank our CEO, Allison Feldman. She's been with us for just a year. Of course, with COVID this year, we had planned to do a conference this fall at Johns Hopkins about now. But with COVID, we knew we couldn't do that. And she could have said, well, this is not a year for conferences. Let's get back to it next year. But she didn't. She said, you know, I've never done a virtual conference. We've never done a virtual conference. There are people out there like you that need the information we have. Let's try it. So we are together here today because she is brave and she is able to pull together something like this. I'd also like to thank 3 of our moderators today, Allie, Megan, and Melissa. They'll be moderating throughout the conference. They are also 3 of our board members. Thank you so much. I'd like to thank all of our presenters for preparing for today and spending your Saturday with us. We are here for your knowledge, for your insights, for your wisdom. Thank you so much. Of course, I'd like to thank our FPA staff, all of the volunteers I've mentioned, plus, of course, our medical advisory board. And last but not least, we have 2 very important sponsors. We have Valley Health System and NSPC helping underwrite this conference. We sure appreciate your help. Now, as you probably have a sense by now, we are here for you. And after this conference, there's going to be a survey sent to you, so we have a better understanding of what you liked, what you didn't like. Now, if you're like me, I'm tired of surveys. I get my hair cut, I get a survey. I change the oil in my car, I get a survey. This is different. We are here to get aligned with your needs. And so we really ask that you complete the survey, send it back. And if that isn't an incentive enough, I understand that names we pulled out of hats and 5 people will receive this invaluable book. Again, welcome. It is now my pleasure to introduce you to the chairman of our medical advisory board, one of the authors and co-editors of this book, Dr. Jeffrey Brown. Understanding of what you liked, what you didn't like. Now, if you're like me, I'm tired of surveys. I get my hair cut, I get a survey, I change your car, I get a survey. This is different. We are here to get aligned with your needs, and so we really ask that you survey, send it back.
Hello.
And if that isn't,
Hi. Do you have something playing in the background? Oh, there we are. Feel free to go ahead.
All right.
You want to feel free to begin your presentation.
Good morning.
Good morning, Dr. Brown.
Good morning, all. My name is Dr. Jeff Brown, and I chair the Medical Advisory Board of the Facial Pain Association. Yes, this is our first virtual conference. Our first real conference was in a small set of rooms at the University of Cincinnati about a quarter century ago, hosted by Dr. John Tu, who is still a member of our Medical Advisory Board. Let me tell you a little bit about it, because you'll be hearing from many of our members. These are individuals who've dedicated a good part, if not the major part, of their professional career to the treatment of facial pain and all its various modalities. They've published articles about it, done research about it, and they are dedicated to this effort, which we have yet to solve. God willing, in our lifetime, we will. During the course of this conference, you're going to hear a holistic view of the care of facial pain. Facial pain starts always universally with a trip to the dentist. So we're going to start with a trip to the dentist. He'll tell you a bit about how an oral surgeon goes about evaluating someone who comes in and says, my face hurts. We'll talk then about how you choose the next level should you need it. If the dentist says, you know, I don't think this is for me or her. We'll talk about the different medical treatments available. We'll talk about the different surgical treatments available. And we'll talk about what happens if the surgery doesn't work. And we'll talk about how you manage your pain should that not succeed. We'll talk about acupuncture, marijuana, psychological assistance, and we'll hear from young people too at the end of this conference. Again, if you don't get it all, it's all in the book. Don't forget the book. Everybody hypes a book when they go on television. I don't know about virtual conferences. Maybe this is a first. So I hope that you'll pay attention. Don't count on seeing this in a repeat. Think about what you're hearing. Ask questions. We'll be here all day. I look forward to speaking again in a little bit of a while, and I look forward to hearing the conference myself. Thank you.
Thank you, Dr. Brown. My name is Allie Kubik, and I am a facial pain patient, and I also serve on the board of directors for the Facial Pain Association. I have had facial pain since I was 13 years old. One of the biggest challenges with facial pain is getting the correct diagnosis. In this first segment, we will get an overview on diagnosis and your treatment options. I would like to introduce Dr. Donald Nixdorf, Professor and Director of Division of TMD and Oral Facial Pain at the University of Minnesota School of Dentistry, and Dr. Michael Lim, Chairman of the Department of Neurosurgery at Stanford University. To ask a question for these presenters, you can scroll down to the bottom of your screen and type in your question, and we will try to answer as many questions as time allows. And now I'd like to turn it over to Dr. Nixdorf.
Thank you, and good morning. I hope everyone can hear me. Greetings from Minnesota. I guess there's some other people that may be other times during the day, like afternoon, evening. I would like to thank the organizers for invitation to this meeting. Can you hear me, Allie? I'm not seeing your expression.
Yes, we can hear you. Thank you, Dr. Nixdorf.
I'd like to thank the organizers. It's a real honor being with you today. As you're probably noticing, I'm looking down to the right. This is where I have my notes written. And so you'll see me doing that every once in a while. So it's what I'm going to talk about today is the diagnostic process. And I'll be covering in this lecture, be presenting it specifically for the patient's perspective, is what is the process that care providers are doing and thinking. And with that, you will see that I don't have slides. And the reason for that is it's more of an interactive component of things. And the material actually can be found in a textbook here that was just recently published by Facial Pain Association. And it covers all this. So I have a chapter in there and other people have some in there. And I think it's really good reference that if for people and family and loved ones, they're dealing with facial pain. And I encourage you to consider getting it. The different people involved in writing the book do not have any financial obligations or interest in that. So all the profits are going to facial pain. So I just wanted to cover that. So what I'm going to cover in the 20 minutes I have here is I want to cover the diagnostic process. That's the first thing. And kind of going through what is the information that we as care providers need and how we go about collecting it. The other part that I'm looking at covering, the second part, what are doctors thinking when going through this process of collecting the data? Kind of the demystifying side of things. And then the third part is I want to kind of weave in what are the various different disorders and how they can be confused with trigeminal and other types of trigeminal neuropathic pain that need to be considered. And supporting a non-slide based lecture is I'm going to try and weave these three objectives in together, intermingling them as I go forward. So from my perspective, the most important thing to know is actually the patient, not the symptoms that they're presenting with. As you probably are thinking right now is this is a little bit on the counterintuitive side. And what I mean by that is patients tend to present and they want to talk about their pain and their suffering, which is very reasonable. But I want to get to know who the person is and how they see and view their pain. So specifically, as a diagnostician, I want to get to first know the patient and all the different components that are possibly presenting and altering how they're feeling and displaying their pain and being able to transmit it to others. So the things that I'm interested in knowing is I'm interested in knowing family background, people's education, people's professions, what hobbies they engage in, because we know that how we grew up, what influenced us, changes the way we think and feel, and those are important ways of understanding. And so we call those the social aspects related to the patient, and there's also the psychological aspects of a patient. What I mean specifically about that can be things like mood disorders, like anxiety and depression, and so they will change how people present, as well as other things like their personality and their temperament. All these factors color, if you will, how you as a patient perceive or think about your pain, and they'll also change how you draw meaning in the suffering in that experience. The other component to it is it also changes the way you, like I mentioned, feel, but also how you express. So it colors or modifies the pain experience in two different ways. And so I want to be clear that it doesn't cause the pain. It merely modifies it and can make it present in different ways, just like different lenses over a camera can change how the information is perceived by the viewer at the end. So we as care providers need to be cognizant of that. And that's why I say that kind of getting to know the person is important, and then what the disorder is they have. An example of that, coming from a dentist perspective, is every dentist knows that the people that are kind of more of the wimpy type patient are the macho type people, the MMA fighters, the policemen, and the firemen. And yet, the flip side to it is the old grandmothers or great grandmothers who lived through part of the Great Depression. They're very stoic and like a rock, tougher than a 200-pound bag of nails. And so you can see how that information, while we were using it to generalize, when we get it from many different angles, we have a decent idea of kind of how the person presents, and that's valuable in kind of interpreting the information that they're giving us. So who you are has a big impact on how you present, and that's why I want to know that before jumping into getting to know the details about somebody's pain condition. Because I can't plug my brain into your nerves and kind of download what's going on related to your nerves, I need to use language to be able to collect that. And that's that interaction. That's where that coloring kind of changes your language. And we know from research is suffering also changes language. So the condition itself has impact on them. And so what we're doing is we're trying to collect information that we can use to fill in the various different diagnostic criteria. And so the most important thing that we're looking at then is which are the ones that are playing a role in what we think is most likely to be going on with you, which we refer to as ruling in the diagnosis. But we're also collecting information about which are the things that are maybe usually come with it or sound like it, but we're trying to rule out those aspects. So we're kind of covering a whole spectrum of diagnoses by asking questions around that. And each one of the diagnoses have specific criteria. So that's why we'll want to go into detail about those aspects. And so when we get into detail, and this is covered more in the textbook that I mentioned about, we'll want to ask things in a very specific way because we can't feel it. And so say from pain characteristics, as a pain provider, I'm going to want to be interested in location, duration, frequency, intensity, severity, aggravating, alleviating factors, perpetuating factors, change with treatments, and so forth. So each one of those goes into quite a bit of time. And so say with the quality aspect of things, I'm going to want to know, is it dull, sharp, achy, throbbing, electric, stabbing, burning? And as you can tell, that detail, and as a provider, I'm going to be kind of digging down deeper and deeper into it. And when there's more than one pain condition, which often is the case when patients are having difficulty being able to get care that is able to address their pain, we often see overlapping pain conditions. Something that's well known in the pain field that we see is pain begets pain. We'll typically see what's called overlapping chronic pain conditions. We need to then tease out those different layers of that, what we're seeing in those. And so those different layers come in different flavors, if you will. And the typical aspects of those flavors is with neuropathic pains is going to be a TMD type flavor, or what I refer to as temporomandibular disorders. These are dysfunction of the jaw joint, jaw muscles, and supporting structures. You can think of it as lower back pain of the face. It's exceedingly common, and so we have about 10% of the population that normally has it. And so when you have a rare disorder that's happening in the face, that's very intense, that impacts the person's life a lot, you can imagine that it's normal for people to guard the area, protect it, change how they chew, change how they smile, change how they use their face, which those changes then, like if you were doing the same thing, if you had a sore back and you kind of moved around, you'd end up with other areas that are sore, and that presents as TMD. It has a component to that that can be dull and achy, which doesn't get mixed up with trigeminal that often, but the background time pain, I think it gets mixed up a lot. The part of TMD that sometimes gets mixed up with trigeminalgia as a specific diagnosis is in the TM joint. You have the feeling part is on the backside, And when the disc is in front and it gets pinched in the back, sometimes that pinch can be exceptionally sharp and have a bright quality, which patients will interpret as a sharp shooting type pain. It feels like they're being stabbed. And they'll report characteristics that are fitting the diagnostic criteria of trigeminal neuralgia, just like the dull, achy, kind of constant, continuous type pain fits some of the neuropathic components when it's muscles of mastication that are playing a role. Another one within the dental sphere that needs to be thought of is dental disease, specifically cracks in teeth. Now, what happens with cracks in teeth is the feeling part within the nerve is actually not irritated until the tooth is stressed, such as biting down on it. It separates the crack. It changes the fluid in the tooth. When that change happens, it stimulates the nerves, and patients perceive a bright, sharp, lancinating, electric type pain that's really intense, and that has components that's very similar to trigeminal neuralgia. And it happens with light touch aspect of things. But one of the key features to help patients separate as well as providers is with trigeminal neuralgia, the light touch, or what we call a beta stimulation, which is just usually light touch or temperature to the skin or offending sensory area, that happens really quickly. But with a crack in a tooth, the classic presentation is not the onset of the stimulation, it's the offset of stimulation. So in that tooth, what happens is you stimulate it, it's when it's let loose, so in other words, the bite is given up, the tooth comes together. That's generally when patients have it. So that subtle difference in the history taking, try and tease that apart, can help providers when trigeminal neuralgia pain or the symptoms are presenting in a tooth, separate those two different entities. So that's kind of what we're kind of going through, and we're trying to pick up some of these things. The problem with trigeminal neuralgia, and you'll hear it probably repeatedly, and a lot of other disorders, is there's no objective findings for it. So in other words, I can't take a blood test, I can't take an image to be able to say so. And that's very difficult because I'm using words, and I kind of went through the importance of those words a little bit beforehand. The other part to it is in dentistry, when we're talking about that crack in that tooth, that crack is really tiny. And so it's beyond the ability for dental x-rays, even the newest types of cone beam x-rays, to be able to reliably pick that up. And dentists know that, and so they're stuck in a situation where they're using your signs and symptoms and how you're describing things to be able to infer, because they can't directly see, measure, or detect the crack in the tooth, which can be deep within the tooth. And that's why sometimes I'll say, well, it sounds like a crack. Well, maybe we can kind of do a procedure, because the only way you can really see it is if you drill inside the tooth, go down, and then look from within with a microscope and a light to be able to easily see some of these cracks that are deep within. So that's some of the kind of limiting aspects of being able to detect cracks in teeth. And that's why there's quite a bit of research in the dental field to be able to develop new technologies such as MRI to be able to detect some of these smaller things. So getting back kind of to the TMD component of things, TMD is kind of a chameleon type pain. It can have that sharp component like I talked about, but there's also the dull achy type component. And when people have overlapping pain conditions, whether they be headache disorders, whether they be neuropathic pain disorders, TMD typically comes with it. Recent research coming that's been published is suggesting that TMD has a major component of central sensitization like fibromyalgia. And so when you see it, there are usually other chronic pain conditions that the person is suffering with. So that's why when you're thinking of a patient that has trigeminal neuralgia, think about TMD. It's probably not the cause of all their pain. It's usually a contributing factor. It's a component that's making pain worse. It's a component of making suffering worse. It's a component that's making it harder to distinguish the disorders, and it's a component that's making it harder to distinguish the effects of various treatments on the pain complaints. So that's why it's kind of an important thing. The good news is, like low back pain, TMD is relatively easy to treat. The rehabilitative approach can be very effective. The bad part about it is it takes time, and it also takes behavioral changes, which we as humans are not always good at changing our behaviors. And what I mean by that is we know things, but we don't always do what we know we're supposed to be doing. And so that behavioral change component of things ends up being a large component of our TMD management that relates to that. So that kind of gives you kind of a quick, brief overview of what we're thinking about pains and how we're looking at it. Other ways that kind of come in is central sensitization, or that sensitive brain type effects happens with patients with migraine. And it especially happens when patients have migraines that are episodic, so they come and go. And then they change to this chronic where they're continuously there, or they're there most of the times and they have this other type of headache disorder in between. Those turn up the nerves, and as a result, different types of pains are felt to be more severe, more intense, more suffering. And as a result, patients also will use words that sound more like trigeminalgia, like when they have allodynia, light touch will be making pain. It's probably not trigeminalgia per se as an individual diagnosis. It's more likely what I would refer to as an epiphenomenon of hypersensitivity, which in itself is bad and harmful, but it's not going to respond to the same type of treatments, and therefore it needs to be thought of differently, because your outcomes of treatment is going to be based on getting the diagnostic correct, as well as understanding how the interplay is. So in the last few minutes that I have here, I want to kind of quickly give an overview about that aspect of things. The most important things that care providers looking at deriving a diagnosis is going to be listening to the patient. We're going to be wanting to kind of understand who they are and how they're presenting. You're going to want to understand them as who they are as a person, how they kind of see things, as well as what they're experiencing, how it's impacted them, and that time, over time, how it may be changed. Often I'll see patients that have had pain disorders for many years. It's not uncommon for it to be 10, 15, 20 years. And taking a careful history of changes over time, you can get an idea about how their pain may have been maybe one disorder to begin with, and then it changes over time. And that's what we see with chronic overlapping pain disorders is over time, new disorders kind of come in because of that, the brain becoming hypersensitive, the thresholds for causing pain become less. We're not talking about inflammation in the periphery. We're talking about sensitization of the nervous system. So that's kind of one aspect that you need to know about. The other aspect to it is what in general healthcare has really been focused off in the history, and that is the identification of local disease that usually causes inflammation. And so the concept there is first off, you look for the obvious things. So it's in the mouth, you're looking for inflammation that causes disease that would account for pain. And when you don't see anything, then you start thinking of some of the disorders, so that rule out process. Now, when you have a patient that's had a disorder, so the sensitive brain for a number of years, you can't always just assume that pain is related to that disorder that's been maintained. Sometimes these patients will pick up new, what we call organic disease or inflammation in that tissue, and that will be a different type of overlapping pain disorder that needs to be addressed and looked at. So you're constantly in this process of reevaluating and looking for new onset diseases, new onset chronic overlapping pains, as well as trying to diagnose them and understand how they're interrelating to each other based on information that patients are able to provide us, kind of managing that information over time to see the picture that is changing, as well as getting good information of how they've responded to past treatments over the time to be able to then predict what your future treatments are. So thank you for your time. This concludes my segment talking about diagnosis and that kind of stuff. And with that, I would like to turn it over to Dr. Lim.
Great.
Hello, Dr. Lim, you are live.
Awesome. Great. Thank you so much. Thank you, Dr. Nixdorf, for your kind introduction and thorough review. Is it okay to start, or do I?
You can
hear you.
seeing your presentation.
Yes, I can see the presentation. Can you hear me?
Yes, we can. We can hear you loud and clear.
Great. So thank you very much for inviting me today. It's really an honor and privilege to be here. I think there are many people in this audience that I've probably met over the years, and really just honored to be here to talk about facial pain. Today I'm going to talk about just an overview of trigeminal neuralgia. I think as you look at the program, we're going to go we're going to get some great granularity in the different treatments for trigeminal neuralgia, but I just want to set the stage today for trigeminal neuralgia. Can you please advance to the next slide? So these are my I just want to make my disclosure relevant disclosures, which I am a consultant for Stryker. Next slide, please. So I think what's really, I think many of us are in the room or in this conference today because we're talking about facial pain. And in particular, when we talk about facial pain, as Dr. Nixdorf said, we have to really take a listen to the patient's symptoms. And, in the case of trigeminal neuralgia, for example, can you go to the next slide, please? Patients present with very characteristic pain. I tell people almost if patients present with trigeminal neuralgia, they present with what they call sharp stabbing pain, electrical pain, or like zapping pain. And oftentimes this pain lasts from a few seconds to a few minutes to sometimes an hour, but then it, stops. It's episodic. Patients say sometimes eating, drinking, or cold wind can trigger the pain. And most of the time it's on one side. However, I do have patients who present with pain on both sides. Okay. Down here in the bottom right is a picture. It's a cadaveric picture showing that the trigeminal nerve splits into three distributions. They call it V1, V2, and V3. V is the Roman numeral for 5, which is why we call it V1, V2, V3. Next slide, please. And so, if you don't mind going to the next slide. When patients come, they tell me that they have facial pain. Oftentimes we're trying to figure out what the cause of the pain is. And so, a lot of people come to me saying that I have trigeminal neuralgia, but oftentimes there are other things that can cause facial pain. In fact, this list is just scratching the surface, right? I've seen people who present with having shingles or herpes zoster in their face. As Dr. Nixdorf said, dental disease is a big part of facial pain in a lot of patients. I've seen patients have problems with orbital disease, autoimmune diseases, and even tumors. Next slide, please. And so, most of the time, and why is it that people get diagnosed with trigeminal neuralgia first? It's actually because it's the most common cause of face pain. And, it causes a significant amount of, not just pain and suffering in patients, but it impacts our society, not just in the cost of care, but also in lost work hours. Interestingly enough, though, even though it's the most common cause of face pain, it's only about 15,000 new cases are diagnosed per year. Now, if you think about it, it's 15,000 being diagnosed every year. It's like a bucket that's filling every year. Every year, there's more and more, which is why we see so many. But about half of them go to surgery, and they often do really well. What's interesting is that, as Dr. Nixdorf was talking about, oftentimes patients have seen a dentist. There's some sort of dental procedure, even orbital trauma or face trauma can trigger this, and nobody understands why. They're not sure it's causative, but it's definitely an association. And in general, it happens in older patients. However, I do see a significant number of young patients who present to me. Next slide, please. And so, next slide. I am so sorry, everybody. There's a very, in the top right, I mean, the top left of my slide, it just, for some reason, I can't see it. So, you know, when people present with trigeminal neuralgia, or they're told they have trigeminal neuralgia, they always think that they were diagnosed with it because they said they saw this on it. They saw a vessel compressing their nerve on an MRI. But I think what I want, and I think what's most important to understand, is that when you make the diagnosis of trigeminal neuralgia, it is a clinical diagnosis. And what does that mean by clinical diagnosis? Clinical diagnosis means that you don't have an MRI, you don't have a CAT scan, you don't have a blood test to be able to tell you what's causing trigeminal neuralgia. It's actually just based on clinical symptoms. And so it's a double-edged sword because, you know, if you have the characteristic symptoms, we can kind of say you have trigeminal neuralgia, but if you don't, oftentimes I always tell my patients, we can't just be so confident that it's the cause and not look for other reasons for facial pain. But you know, as we said, the most common reason for patients coming to see me and being diagnosed with trigeminal neuralgia is that they see this vessel touching a nerve. And if you look down in the bottom right here, you can see, hold on for 1 second. You can see that there's a vessel touching the nerve here in the bottom right. Okay, next slide, please. And so how this is diagnosed is on an MRI scan, or how they make this determination is on an MRI scan. Go to the next slide. And what they do is they get these high resolution scans. Sometimes they call them Fiestas, Drive FISP, whatever the proprietary name of it is. It's just based on the machine that they're using. And so next slide, please. So if you look, can you just slowly progress through the next 4 slides? If you look here in the right, and I don't know if you can see my mouse or not, but right in front of the brainstem, you can see a little vessel going over the nerve. Can you see my arrow?
Sorry, doctor, we cannot.
Okay. Well, they're going to go over this in more depth in the MVD talk, but basically, in this case, this is what the findings are that people come to see us with. But again, what I want to stress is that this is not a pathologic finding. Just because you have a vessel touching the nerve doesn't mean that you have trigeminal neuralgia. At the end of the day, it's a clinical diagnosis. And what that also means is that sometimes when we treat patients, we're trying to take care of patients for their pain, but we're not necessarily, we don't always know the cause. Next slide, please. And next slide. So then people say, well, why is this MRI so important? So the MRI is what I tell people use to rule out other things. So as an example, you can see in these 2 MRIs, these 2 patients came with facial pain and they ended up actually having a tumor. And the tumor was actually causing the face pain. Sometimes other things that can be seen are things such as multiple sclerosis. They can see inflammatory conditions. They can see infections. The MRI is very important because sometimes we can find the other cause of facial pain in patients. Next slide, please. So, you know, today they're going to talk a little bit about treatment. And so once we get, a lot of patients do very well with medical treatment. They're treated with things such as Tegretol, Baclofen, and Dilantin. And if you notice the treatments, and most people who've had medical treatment in this audience realize that these are all seizure medications. And so what many of us believe is that this condition is probably a seizure of that nerve, like a mini seizure, which is why you're getting this facial pain. Some people believe that the artery rubbing on the nerve can cause the myelin or the insulation to rub off, and the nerves are literally short-circuiting. And that's why these seizure medications work, but we don't ultimately know that cause. But, you know, when patients who, and most of the time, though, patients respond very well to these medical treatments. Next slide. But, you know, there are a subset of patients who either become resistant to these medications or the medications just fail them. there are some great surgical options which are going to be discussed in detail today. There's something called the microvascular decompression, the rhizotomy, and the radiosurgery. Next slide, please. Next slide. So, later today, they're going to talk a little bit about a rhizotomy. The rhizotomy is what I call an ablative procedure. If you just look at the three procedures kind of from 30,000-foot view, two of the procedures are what I call ablative. What they're doing is they're causing some damage on the nerve to stop the nerve from short-circuiting. The damage is usually not permanent because the nerves have this ability to regenerate. And then the microvascular decompression is trying to really fix the problem, and that's a more durable response. But this is a rhizotomy. Basically, you put a needle right here at the cheek, and you pass it right up to the bottom of the skull, and you try to burn the nerve either with a chemical or heat. And it works very well. Next slide, please. The microvascular decompression, which I think Dr. Brown and Dr. Sakula will talk about, again, works on the idea or that concept of trying to, next slide, please, take an artery off of the nerve. And, Dr. Janetta did a lot of work on this. On the left, you can see the vessel touching the nerve, and on the right, you can see the cushion pushing the artery off of the nerve. Next slide. Historically speaking, though, it's interesting. Dr. Janetta really perfected the procedure. Walter Dandy, who was the second chairman at Johns Hopkins, was the neurosurgeon that was thinking about, was actually the one who thought about trying to take the artery off of the nerve. So I think you're going to get some great historical context later. The last one is called stereotactic radiosurgery. And again, this is an ablative procedure. Basically, what you do is you take tiny beams of radiation and put it on the nerve to cause the nerve to be damaged and stop the nerve from seizing. And, that's a non-invasive approach. And again, has been very effective, but there are pros and cons. Next slide, please. So, as we go through this, people will talk a little bit about, I think in today's world, they're going to talk about cost. Sometimes when people show you these slides, and I've seen lots and lots of these slides, of course, the microvascular decompression is more expensive than some of these things called the rhizotomies and radiosurgery. But I say you always want to go back to the original concept of these treatments. The microvascular decompression is to really take the artery off of the nerve and try to cure this. And so I tell people there's usually a one-time cost, and then with these other procedures, you'll have to have it done repeatedly over your life. And so it's an additive cost. Next slide, please. And so, I think over the day today, I'm just kind of summarizing the success rates and the complication rates of all the different treatments. In general, all the different surgical treatments work really well and can be very successful. You just want to be at a place that does a lot of these. Complication rates vary. If you do an ablative procedure, there are higher rates of numbness. There's a small chance you can make the pain worse, such as with the rhizotomies or with radiation. The microvascular decompression has a high chance of not causing side effects, but it is more invasive. And so, as you can see, for example, the facial numbness rates are significantly higher with the radiofrequency, the glycerol rhizotomies, as well as with radiation compared to microvascular decompression, because you're not damaging the nerve. And but the recurrence rates are higher, obviously, for those procedures because you're just trying to nick the nerve, and so the nerves will naturally regenerate. Next slide, please. So, I want to acknowledge that, there was a lot of great people on my team. I think that it's important that wherever you go and choose, you have a great set of team. I mean, a great team that to take care of you. Remember, it's not just the surgeon, but the team that's around the surgeon, the OR nurses, the the PA or the NP that's also in the office. You want to make sure you have a group of people that know this disease and can take care of you. And so, a couple things the takeaway points from this is, first of all, trigeminal neuralgia is a clinical diagnosis. Remember that. That means we don't have a blood test, we don't have an MRI, we don't have a CT scan that can give you that diagnosis. Oftentimes, patients are led to believe that just because there's a vessel touching the nerve that they're diagnosed with trigeminal neuralgia. As a result, I think that's why, because we don't know for sure you have trigeminal neuralgia, and we base our treatment recommendations on clinical diagnoses, that sometimes these treatments don't work for everybody. And as a result, when you have facial pain, and as you've seen, sometimes tumors form and other things, it's important to get a good workup. And I always tell people you want to do workup over time. Remember that, sometimes we'll get better technologies and we may ultimately know the cause of someone's pain 5 years from now. So it's always important that you follow up with your primary care doc and your neurologist to continue workup of your pain if for example, you continue to have pain after these procedures. The other thing is that, medicine works really well, but when it doesn't work, when it fails you, that there are some really great surgical treatments, and you kind of break it into two big concepts. One is what I call an ablative procedure, and the other is kind of trying to fix the problem. So with that, I hope that this kind of sets the foundation sets the stage for the talks later today. So with that, next slide, please. Next slide, please. I just want to acknowledge again that there's a great clinical team that helps, and we do research. With that, I'd like to say thank you, and we're happy to take questions.
Thank you, Dr. Nixdorf and Dr. Lim. Just a quick technical note, during the conference, if you are having difficulty seeing the slides, there is a way for you to change the layout. So all you have to do is click on the slide and it will give you the option to change the layout. All right, doctors, I have some questions from the audience for you right now. The first one is going to be for Dr. Nixdorf. Can facial pain look and feel like a sinus infection?
I would say yes. So the type of facial pain that I think most mimics a sinus infection is T&D type pain. That is a dull, achy type pain that sometimes changes with posture. Is usually pain in the lateral pterygoid muscle, and it's referred. So that's a muscle that's deep in the jaw, and it's referred usually up into this kind of sinus antrum area, and it presents usually as dull ache and pressure.
Okay, thank you, Dr. Nixdorf. Let's see. This one is going to be for Dr. Lim. Do you see a lot of people presenting with multiple types of facial pain? Trigeminal, geniculate, glossopharyngeal?
So yes, I do see. So first, I want to apologize. I'm at home. We have a busy house, so I'm sorry for the background noise. But I want to say yes, I do see patients with different types of facial pain, the geniculate neuralgia and glossopharyngeal neuralgia. I think the common thread between some of these is that there's sometimes a vascular compression that's noticed. But the way you kind of differentiate those tumors, those types of pains is basically it's electrical wiring. So trigeminal nerve is really the face. The geniculate neuralgia is usually pain that goes right in the ear. And glossopharyngeal neuralgia is pain that's really kind of more in the back of the throat or the palate. And so again, it's just like they're just different rooms in the wirings or different regions of your skull. But a lot of times people still have this sharp pain with it. It's just a different location.
Thank you, Dr. Lim. Another question for you, Dr. Lim. Can you speak about the progressiveness of facial pain?
Yeah, so I think in terms of progressiveness of facial pain, that's It's an interesting question. So if we break into two categories, right? If you have facial pain that's not from trigeminal neuralgia, that's, for example, progressive, it's usually indicative of some sort of process that's going on. It could be a tumor, it could be inflammation, it could be some sort of infection. And so, when you see it progressing and it's not characteristic of trigeminal neuralgia, I always say it's very important that you make sure that you partner with a good neurologist or a doctor who's invested in your diagnosis. For trigeminal neuralgia, it is not uncommon for patients to present with progressive facial pain also. And oftentimes it's manifested as increasing frequency or intensity, and patients usually have to dial up on their medications. And eventually, when they progress, usually patients end up needing a surgical procedure at some point.
Okay, thank you. Dr. Nixdorf, a question for you. Could you speak about burning gums?
Sure. So burning gums, also the other terms for it would be glossodynia or burning mouth syndrome. Those are kind of synonymous terms. And so the research about it would suggest that it's pointing towards it's a type of neuropathic pain. It's one that affects small fibers. And in that case, that's why it presents in both sides, the left and the right side. So it's not like a nerve injury that's caused from a procedure. It's more of a metabolic aspect of things is what we're thinking. And with that type of pain, 50% of patients respond with topical clonazepam. So this is something that you would periodically put in your mouth in the areas that's affected, hold it for a few minutes, and do that 3 to 4 times per day. And that is able to greatly reduce that type of pain if it's specifically burning mouth syndrome.
Thank you very much, Dr. Nixdorf. Another question for you. Any suggestions for visiting the dentist? There was a question that came in about vibration in the mouth can set off facial pain. So any quick suggestions you would have for visiting the dentist with facial pain?
Yeah. So that is a big question. It's one that I get often. And a number of years ago, I wrote a small little piece for the Facial Pain Association, and I can easily send it to the organizers and they can post it on the website or stuff. The difficulty is there's not a lot of research that's done on that area because, one, trigeminal neuralgia is relatively rare, and two, being able to kind of interact in that way has been difficult over the years. So the piece was written about more of a theoretical way of addressing it, which I put into practice with my own patients that are seeking dental care. It seems to work. And there's several parts to it. One is to optimize, when you can, the control of your trigeminal neuralgia. And so one of the things is if you're taking medications, sometimes when patients go up on medications, they get unacceptable side effects. But in the short term, those side effects may be worth it to decrease the chance of having a flare-up. So in other words, being able to increase their current pain to get a little bit better control. I use the analogy is that the nerve pain is kind of like a forest fire. And so what you do is your regular treatment is like a wet blanket over that fire, the nidus. You've got it under control. So why not put a bigger one of the same type of blanket over top of that to decrease the chance of it flaring up, because we know vibration and touch play a big role in triggering it. So that's one part. The other is people's anxiety and fear. So in other words, our own ability to turn up pain is actually increased when we're worried about it. And people with chronic pain disorders have an increase, and it's rightfully so. People that have trigeminal neuralgia are worried about seeing the dentist because things get worse and they suffer a lot. So sometimes treating that, it's not known what the best way of treating it, whether it be medications or talk therapy, but conceptually, whichever way you do it, I think would be helpful. And then there's components of after the dental treatment, you may want to be thinking about managing the inflammation. So this is a case where, yes, NSAIDs don't usually work for neuropathic pain, specifically trigeminal neuralgia, but you may want to be taking NSAIDs before and after dental procedure to mitigate the aggravating factors associated with the inflammation that the dental procedure causes. And so that case, you may want to be treating that inflammation. Same sort of thing goes.
Okay, thank you so much, both Dr. Nixdorf and Dr. Lim. I would like to turn it over to Ann Smecki now.
Good morning, everybody. It's so nice to be here today, and welcome to everyone from across the United States and across the world. My name is Ann Smecki, and I'm the Secretary of the Board of Directors of the Facial Pain Association. I'm also a support group leader and a peer mentor. I am a person with facial pain, and I've also been a caregiver for people with facial pain. Both my mother and my grandmother lived with trigeminal neuralgia. Our next presentation is about microvascular decompression, which you may know by its acronym MVD. I'd like to bring back Dr. Brown to discuss that. And after Dr. Brown speaks, we'll hear from Dr. Raymond Sekula. Dr. Sekula is from UMPC, or the University of Pittsburgh Medical Center. He's an associate professor of neurological surgery there, and he's also the director of the residency program. If you have a question for either of our presenters, please type them in the box on the bottom of your screen, and we'll get to as many of them as we can when our speakers are finished. So Dr. Brown, it is my pleasure to turn the program back to you.
Thank you, Ann. Let's see my first slide, if that will come up. So yes, the doctor is looking over you who have pain, and that's the electric shock of it in the lower corner. And by the way, I would like to thank our sponsors, the Valley Stream Hospital Center from New Jersey and NSPC from my own Long Island. So I'm going to focus on the beginnings, not the surgery itself, but how do you choose to do the surgery? When do you choose to do the surgery? So let's go to another slide. And here's the problem. I want to get away from this idea, do I have trigeminal neuralgia? Do I have this? Do I have typical that? Do I have atypical that? I want to use the term trigeminal neuropathic pain, which is kind of an umbrella for all the kinds of pains that we're talking about. Now, you heard Dr. Lim discuss that this is a, quote, clinical diagnosis, meaning if the doctor says you have it, you must, because that's the meaning of clinical. But I'm going to talk a little bit about how do you accurately characterize the nature of this pain. So let's try another slide. Important fact, facial pain is not purely one thing or another. Dr. Nixdorf did a fabulous talk on how the pains can be mixed, and it can be a little bit of that and a little bit of that. I'm really impressed, and we're really lucky to have had him speak here. But I want to focus on something called the McGill Pain Questionnaire, which is what I ask all my patients to fill out while I'm trying to evaluate whether they have trigeminal neuropathic pain or something else, and ultimately whether I think they require an operation, and ultimately which operation. Because, by the way, when you see that surgeon, and I'm a surgeon, Dr. Lim is a surgeon, Dr. Sekula is a neurosurgeon, we're all neurosurgeons, you want to ask as the first question, believe it or not, well, what if whatever you do doesn't work? Can you do something else? Because if it's a doctor with only one hammer in his arsenal, you don't want to be that nail. You want to be a doctor who has a whole set of arrows to attack this entity. So on the bottom of your screen on the left, there are a series of words that I want to focus on. And first of all, you don't want your doctor putting words into your mouth. You want to put your words into his head. So on this checklist, there are things which have a long name called paresthesias. Number 2, it says jumping, flashing, shooting. They're called spatial descriptives. And I ask the patient to check off if any of those 3 words in that box describe the pain. You get one choice to describe it. Well, clearly we hear about shooting, but jumping may be a little bit less than shooting. Not everything is at the extreme, so they do that. Next box, it's the punctate quality. Is it pricking a little bit, boring deeper, drilling deeper yet, then gets stabbing, and ultimately we get to this word lancinating, which comes out of the historical textbook of, quote, classical trigeminal neuralgia. Classical just means that it was someone 200 years ago describing those patients that they could make sense out of. But not all the patients, even then, had classical trigeminal neuralgia. Those were just the ones that can identify that. But there are patients who have a large component of what are called dysesthesias, constant, odd feelings. To the right, thermal quality, hot, burning, scalding, and even more intense searing. That's had to be around 250 years ago, but yet we say that's not classical. Well, it is classical. It's part of this entity. The other elements are what are called brightness descriptives, tingling, itchy, smarting, stinging. All of those can be a part of what you feel as a patient. But many of you feel elements which are called nociceptive, which are those pains that are picked up by nerves as opposed to those pains that are caused by nerve. Nociceptive pains are the things that happen if you cut your hand, you get that pain, which you describe as dull, sore, hurting, aching, or heavy, or pinching, pressing, gnawing, cramping, or crushing. Those also may be a part of your trigeminal neuropathic pain, and there can be a mix. The question is, which is predominant? And that still doesn't tell the surgeon what to do, but if the paresthesias and dysesthesias aren't there and the nociceptive elements are, then we have a different entity. So thank you. So what I like to talk about, not to confuse you terribly, but this is how I approach it. You can have trigeminal neuropathic pain, which has a predominance of the paresthesias. They can be there constantly, repeatedly, when it's severe, or intermittently, or there's a predominance of the odd feelings, the dysesthesias, the constant prickling, tingling, burning sensation, or they can be a mixed. All of this is part of the decision-making process that I need to go through in deciding, do you have an entity that could possibly be treated surgically? So this is an example of a McGill pain questionnaire filled out by one of my patients who has a mixture of all these different things, but they do have a predominance of neuropathic elements. They have flickering pain, shooting pains, stabbing pains, sharp pains, but they also have elements of crushing, pulling, burning, tingling, hurting. It's a mixture. It's not one thing. So it is something that needs to be carefully evaluated. And these can be quantified too. So I like to have numbers, and I can come up with a number that tells me, yes, I think we should go to the next step. And what would be the next step? And that involves medicine. Let's see what the next slide says. I'm not focusing on the medical treatment, but let's assume this patient has had medical treatment, and they usually have had medical treatment with an anticonvulsant drug before they get to me. You know, a word about medicines. Anticonvulsant drugs work by slowing down the electrical conduction of the brain and the nerves through the whole brain. And that's how they help the hyperactive element of this trigeminal neuropathic pain. So they can affect your thinking, your walking, and they can make you drowsy because the brain doesn't function as well. All that's necessary to get to the source of the pain, which we think is this artery pounding against the nerve and stripping the insulation such that electricity short circuits when it goes through the nerve. If you turn down the electricity, then you don't get the short circuit. If you turn off the switch, you won't get the short circuit. So the medicine is designed to do just that. I will mention that there has not been a new medicine approved by the Federal Drug Administration for the treatment of trigeminal neuralgia since Tegretol was approved, God knows how many years ago. But I would also like to say that there is at least one research study which has been started out around the country and at my institution for a drug that works in a different way from these anticonvulsant drugs and should not make one drowsy. So that's kind of exciting to me. It's just getting started, and you can ask about that at a later point during the conference. So this slide shows on the top a side view of an MRI that's done with a special technique. So all MRIs are not equal. Let me say that again. If you get sent for an MRI by your doctor, that doesn't mean it's going to be useful. One needs to get an MRI that uses these acronyms, FIESTA, CISS, because they allow us as neurosurgeons to see the brain, the nerves, the spinal fluid, and differentiate them and do it with very thin cuts. So it's not just how big the number is with your MRI. We'll get you a 3 Tesla MRI. That may be fine, but not perfectly fine unless they use the software technique that allows one to see the nerves. So if you're going to get an MRI, you need to know that you're going to get an MRI with a FIESTA or CISS technique, and it should be done in what are called 3 planes. On the top, it's called the sagittal plane, from the side. On the bottom left, it's called the coronal plane, looking straight at you. And from the right, it's called the axial plane, meaning cuts through the head, actually looking from underneath. The blue arrows point to the artery that's on the nerve, and one sees it in 3 different planes at once. So I, as a neurosurgeon, know exactly what the problem was. I know exactly that one has vascular compression of the trigeminal nerve. So, next slide. This is what it looks like in an anatomy dissection. It says CN5, cranial nerve 5, and the blue thing is actually a vein. It doesn't have to be an artery. It can be a vein. The blue thing is a vein that lies on top of the nerve. Next slide. There's the arrow. Next slide. Or here we see a real dissection. There's the red arrow pointing to the red artery that's stuck on top of the nerve. And this is what the MRI needs to show the surgeon. So there's no exploratory neurosurgery. It's not quite like what Dr. Nixdorf was talking about with the dentist, that you can't see the crack, and so maybe you need to do some exploration. No, I never explore. I only operate if I know exactly what I'm looking for. It can be difficult if it's a reoperation, and we'll talk a little bit about that later on. Next slide. So this is kind of complicated, but what it demonstrates is that there have been studies where biopsies were actually taken of the trigeminal nerve underneath one of these arteries or veins that show a total disruption of the normal insulation on thousands of the wires within the nerve. It's not a hypothesis. I believe it's been shown that trigeminal neuropathic pain associated with vascular compression of venous or arterial nature does injure the nerve. So on the top left, there's a normal looking cross-section with electron microscopy of a nerve with this dark circle around it. That's not the whole nerve. Those are individual fibers in the nerve. And that's what it looks like normally. All you can tell on the lower slides is it's a total mess underneath that artery. There is nerve injury that goes on, but nerves can heal. So if you take the artery or vein off, the nerve can heal because the myelin can regenerate. The nerve can't if it's totally cut. So we don't want to cut the nerves. I don't. But the insulation can heal, which is why if you take the artery off and it stops pounding on that nerve, just think of hitting your funny bone over and over and over again. That hurts. You stop pounding, you can start to get the pain to go away. And that's what we do with microvascular decompression. Next slide. Dr. Lim mentioned Dr. Janetta's study, which was documented very carefully by one of his students. And this is what's called a survival curve for pain-free days. So if you look at the left side of these curves that show that of say 100 patients who have the MBD, we start out on day one with 90 of them being free of pain. That's pretty good, but it's not perfect. And even though 90 are free of pain on day one, there's a gradual drop over the next 15 or 20 years, most of which occurs in the first 5 years, if it's going to, where the pain can recur for any number of reasons. Maybe the surgeon's not perfect and he missed something. Maybe something new happens. Maybe there's something different in the terms of the medicine that they're still taking. Veins, by the way, can regrow. Arteries can't regrow. If an artery is moved, it should stay away. Teflon doesn't jiggle away. And Dr. Sakula will talk about that element. But veins can regrow and new problems can occur. Next slide. So you can see these curves are survival curves for what are called ablative treatments, meaning things that are done to injure the nerve to slow down the amount of electricity going through it. There's, on the bottom, radiosurgery. There's, on the top, balloon compression and radio frequency. The recurrences are 30 to 50% in the first 3 to 5 years. I'll say it again. 30 to 50% of patients who have something that's done to injure the nerve have recurrences in the first 3 to 5 years. With the microvascular decompression, 15% may have a recurrence after 20 years. So it's quite a bit different. Next slide. Studies have shown, and this was done by one of our former Medical Advisory Board members, Joanna Zakrzewski in London, that the best quality of life after surgery for trigeminal neuropathic pain is achieved with a microvascular decompression. Now, I want to talk a little bit about what questions you need to ask your doctor if he's offering or she is offering a microvascular decompression, because these are the things that are done in preparation for the surgery. There are other cranial nerves nearby that have to be carefully monitored because they can be injured. We have to monitor the function of the hearing nerve. We have to monitor the function of the facial nerve that moves the facial muscles. We can monitor the function of the trigeminal nerve. We can monitor the function of the brainstem because we're moving an artery. It could cause a stroke. We do what's called intraoperative monitoring during surgery. We don't do this blindly. And there's an individual constantly monitoring the function of your nerves and brain during that surgery as kind of an additional co-pilot to the surgeon and to the anesthesiologist who's monitoring your heart rate, your breathing, and your oxygenation. So you want to ask your surgeon, do they do that? Now, some neurosurgeons will talk about endoscopic approaches, that they can see more if they use something called an endoscope. My belief, and it's not been disproven by any study, is that if you know what you're seeing before you do the surgery on the MRI, you don't need to explore with additional scopes. And a microscope is quite adequate. So there is no statistically shown benefit for something called endoscopy. Question, we're going to use a pillow, and Dr. Sakula will talk about it, called Teflon. Does Teflon itself cause injury? There's no proof yet that it does, though there may be discussion about that, but there is no study that shows Teflon itself causes injury. And finally, you want to find out if your surgeon is doing this MBD, has he done it 100 times, 500 times, 10 times, 1 time? Every surgeon has to have a learning curve. Not many of us want to be at the beginning of that learning curve. Next slide. So before I turn it over to Dr. Sakula, as you go through this hunt in this mysterious way, I want you to find your own way. Next slide. And hopefully that way is the way to your health. Thank you.
Hello, Dr. Sakula, can you hear us?
I can.
All right, if you don't mind, you may begin.
Okay, great. Let's move to my first slide. I'm delighted to be here, and I appreciated the talks from Dr. Nixdorf, Lim, and Brown, and I'll try not to be duplicative in my content, and hopefully try to answer some questions about microvascular decompression. Next slide. I have no disclosures. Next slide. And I want to follow a little bit on what Dr. Lim was mentioning. You know, there are many different types of facial pain. And the one type that we do probably the best with, one of the types that we do the best with operative procedures is a so-called classical trigeminal neuralgia. That is now the accepted term by the International Headache Society and the International Association for the Study of Pain, and a number of other consensus groups comprised of neurosurgeons, neurologists, and other clinicians. But there are many different types of pain, all of which are very debilitating and require really a lot of careful thinking. And so, as Dr. Nixdorf and Lim and Brown suggested, the first thing that I try to do is determine what type of pain does the patient have. And I'm not always successful at that. I don't love the term atypical trigeminal neuralgia for a couple of reasons. One is, unlike these other entities listed here, we really don't know what that means. It also kind of makes a patient feel odd or weird. And there's nothing weird about having so-called atypical trigeminal neuralgia because it's really pretty common. In fact, it's more common than so-called classical trigeminal neuralgia. But for the purposes of this discussion, let's go to the next slide, please. Classical trigeminal neuralgia is an entity that one can diagnose just in talking to a patient. And it's a patient who has the onset of sharp and shooting pain that's always brief. It can happen over time, hundreds of times per day, but it's a brief type of pain. Women, for instance, I don't want to sound overly familiar, but women will always say it's worse than the pain of childbirth. Men say it's worse than pain of fractured bone. It's a really unique type of phenomenon. And in the last, I'd say, decade and a half, there's been more attention paid to imaging of the trigeminal nerve. And just because of the logistics of this virtual conference, I didn't get to hear all of Dr. Brown's talk, but I did hear Dr. Nixdorf and Dr. Lim's talk, respectively, in their entirety. And at least as Dr. Lim suggested, just having a blood vessel on your MRI doesn't tell us the entire story. Next slide, please. So I want to highlight this. This is a study from a very good group of neurologists. This is from the Danish Headache Society. And, you know, it's a little bit of a busy slide for a non-medical person, but if you look at the top box that's outlined in red, just above that, you'll see the symptomatic side and the asymptomatic side. So the symptomatic side, what is this, the side of the pain that the patients are having. So this particular group of neurologists looked at 35 consecutive patients who met the diagnosis of classical trigeminal neuralgia just by talking to them, by symptoms. And if you look up there under the symptomatic side, you'll see that 11% of the patients who underwent high-resolution MRI imaging, like you've been shown earlier, had no evidence of any type of compression of their nerve. So what that tells you is that some patients with classical trigeminal neuralgia will not have a blood vessel compressing their nerve. And so from my standpoint, they are not candidates for microvascular decompression. That's really just very voodoo. And you know, at least I personally began working in earnest on imaging in 2011. At that time, it wasn't well accepted. It's becoming more accepted. But I think it's important to highlight this because, for instance, both the International Headache Society and the International Association for the Study of Pain have now come around to saying that classical trigeminal neuralgia has a blood vessel compressing the nerve, and that's part of the diagnosis. And in fact, it is not. If you look at the box below that, you'll see simple, severe, and displacement. And what these authors were trying to show is that there's a real variety of what you see on an MRI, whether there's, next slide, please. Whether there's merely just contact of the nerve, or whether there's a focal compression from a blood vessel, or whether the blood vessel actually distorts the morphology of the nerve, as you're seeing here. Thank you for that, Anne. And so, you know, in the upper left image, you'll see that there's a blood vessel just in proximity. And so often I see operative reports from surgeons saying, well, there was a blood vessel close to the nerve. Well, to my mind, that's kind of like saying, you know, the patient was almost pregnant. It just doesn't make any sense at all. There's today the MRIs are so good that we can really tell whether there is on the upper right contact of the nerve, or a focal compression like you see on the lower left, or a frank distortion of the nerve. Next slide. Okay, so we'll come back to that in just a minute, but I want to talk again about, you know, microvascular decompression and who it's right for and who it's not right for. Well, the short answer is we don't always know. We do our best as clinicians to help determine that, but this is a paper that was published in the early 2000s, but it was really based on a lot of Dr. Janetta's patients. And Dr. Janetta operated for a lot of patients with both so-called typical, which nowadays would be pretty much the same as what we're calling classical trigeminal neuralgia, and then the so-called atypical trigeminal neuralgia. And that's harder to group those people because We know they didn't have tumors, but they might have had herpes zoster. They might have had some sort of injury to the trigeminal nerve, or they may have had none of those diagnoses and truly just had this other type of trigeminal neuralgia, which is, it's just more of a constant, boring type of pain that usually worsens throughout the day as a person uses their mouth and speaks. And let me make it very clear, you're not a good person if you have classical trigeminal neuralgia or non-classical or atypical, but there is a difference in how you might respond to a microvascular decompression. And if you look at the box that's outlined, those are the patients with a cure. You can see that after a certain number of years, more than 73% of the patients were cured of their pain who had the so-called typical or classical trigeminal neuralgia. And only 35% with the atypical or non-classical trigeminal neuralgia were cured with microvascular decompression. Next slide, please. So, you know, what I often hear from patients when this conference was live was, I'm so confused. I've met with 2 or 3 surgeons or neurologists, and I've gotten different opinions. And what should I do, doctor? And you know, is microvascular decompression right for me? And in Dr. In Dr. Janetta's days or Dr. Tu's days, Dr. Tu, I think maybe with us later, really excellent surgeon from Cincinnati that did a lot of good work in trigeminal neuralgia patients. In their days in their heyday of operating, I should say, the MRIs were available, but they just weren't refined enough to be able to look at the nerve the way we can now. And in fact, when I operated with Peter Janetta for many years, I mean, he paid no attention to the MRI with the exception of just ruling out whether there was a tumor present. So we did this study, and it looked at a few hundred of our patients. Now, understand this is just a study from our patient. It's not a multi-center study, and our hope is that other surgeons will apply these criteria to their patients and see how their patients do. Let's go to the next slide. But we took known predictive factors. So those factors that we know are predictive of individuals who will respond better to microvascular decompression from multiple studies from other groups. And so the first one was, do you have classical or some other form of facial pain? Did you respond to medication? And the only medications for the purposes of this talk that matter are carbamazepine or Tegretol or oxcarbazepine or trileptal. And there's some sophisticated reasons about the certain channels that those drugs control for why that's important, but we assigned a point or no point. So in other words, did you respond early on to the use of that medication? Did it relieve your pain partially or completely for a time? Then you get a point. And then we looked at the amount of vascular compression by a high resolution MRI. And we assigned 1 point for no contact or just a vein, and 2 points for an artery focally compressing or contacting, and 3 points to those individuals with deformity, which gave you a total grade of anywhere from 1 to 5. Next slide. And I try to tell patients in a way that is not patronizing that where you fall on this scoring system doesn't make you a good or bad person. It just is what it is. And so, you know, in our patients, this was at about 3.5-year follow-up. If for those patients with a 5, more than 90% were still pain-free without any medication. For those with a 4, 76 were pain-free without medication. But if you go down to, say, 2, 16% were. And I think very few individuals would choose to undergo microvascular decompression if they knew they had somewhere in the neighborhood of a 16% chance of success or pain-free status after the operation. Now, pain-free is not the only measure of success, and I'm going to talk a little bit about that. Let's go to the next slide, please. So, as Mr. Myers suggested, we have a new CEO, Allison Feldman, and her partner, Melissa, who's also a patient with trigeminal neuralgia, helped me with the next few slides to try to answer questions that patients frequently ask about microvascular decompression. I really appreciate that. And so one of the questions we hear a lot from patients is, what can I expect following in microvascular decompression? And, you've heard a couple of surgical experts earlier in the conference. And so, for those types of elite surgeons in this area, you can expect a reasonable post-operative course. But even in the best of hands, you're probably going to experience some post-operative nausea, some headaches, maybe some imbalance. And so that's to be expected. In most patients, the first night is the worst. In my practice, what I often see is I go by, I see the patient after surgery, and they're sitting there, they're eating, they're laughing, they're telling me, my gosh, I thought this was going to be so much worse. And I say, well, hold on a second, it might get worse. And then I come in the morning, and they say, oh, that night was tough. Not everybody, but some people will say, it's bad headaches, and I was up all night with nausea, that kind of thing. So the first night's usually the worst. In terms of what restrictions, that depends on the surgeon, and I don't want to say too much about that. I mean, I certainly let my patients get up right away. I think patients can usually drive in pretty short order as long as they're not taking any narcotics. And I think for most surgeons, you should really be pretty darn close to back to normal within a month. Another question patients ask is, what should I expect from my surgical team after a microvascular decompression? And again, I hope I'm not duplicating anything from Dr. Brown's talk. I couldn't see that. But what Dr. Lim kind of mentioned at the end of his talk, this big team of people that he works with. And that's really important. The surgeon really can't do it all himself or herself. You've got to have an excellent team in the operating room. That's really critical, because when you're doing the decompression, you've got to have somebody that knows how to hand those instruments to you, make the pieces of graphs that you're going to use for you, those kinds of things. But outside of the operating room, the surgeon should be to some extent available to you, and should at least have a proxy team that's available to you to answer questions. Like, for instance, I just before I got on this call was responding to the wife of a physician who has glossopharyngeal neuralgia, and I just operated. And she said, it's now day number 3, and he had felt great the first 2 days, and he's at the hotel, and they were just getting ready to leave, and he's really feeling quite nauseated. So, they just emailed me, and I just gave them a call. And during the week, sometimes that's me if I'm sometimes that's my nurse practitioner or my nurse if I'm in the operating room. But that's kind of, I hope, what you should get from a surgical team. Next slide. Some patients ask, well, what is success following a microvascular decompression? And is complete pain relief the only form of success after microvascular decompression? And I would say, absolutely not. I mean, that's the hope for both every patient and every surgeon, but it's not always. Patients will come. I saw a young fella yesterday. He's 23, and he's had trigeminal neuralgia for 6 years. And his is, kind of different. It's because he has a congenital disorder called osteogenesis imperfecta. But what was really, he's now out of pain, and that's great. But his mom said to me that he lost the last 3 years of his life. In other words, he just had no quality of life. And so he was on because of the 4 or 5 drugs that he was being maintained on. So she said he was often angry. He was lethargic, or he's sleeping a lot of the time. He's very confused. And, he's only in his early 20s. So this is really sad. He's now out of pain completely, and he's tapering off the last medication, Lyrica, which is great. And I really hope he'll stay free of pain. I spoke to another patient of one of the surgeons that's involved in this conference, and she told me, well, I just recently had some recurrence of pain, and I'm taking one medication about 1/5 of what I used to take. I was totally non-functional before that. It's nothing like the pain that I had before this surgeon did the microvascular decompression. I feel like it was a tremendous success. I agree. So there's different forms of success. Some patients will come to me and they've had multiple ablative procedures, and now they have some numbness in their face, even profound numbness, but they have either had a recurrence of the very sharp intermittent pain, or they never got rid of that sharp pain. And what I have to explain to them is, I can get rid of your sharp pain. I cannot restore the sensation in your face. I cannot fix the numbness that's been caused. But we can still do you some good in this area. So we just try to, every patient's a little bit or patients are a little bit different. And what you need to remember is that microvascular decompression is not a permanent cure for some patients. If you think back to that grading scale outcome I showed you, and I just have a few more slides, but for instance, in our grade 5s at 3.5 years, 93% are pain-free. My guess, and it's only a guess because I'm going to need to follow these people, my guess is that they probably won't dip below 80 or 85% over 15 or 20 years. That's what I think. When you look at some of the other long-term outcome studies, let's say from Dr. Janetta's work that was published in the New England Journal, those very best candidates went down to about 68% pain-free at 10 years. But you have to remember, he didn't have imaging to supplement his work. So now with the imaging, we really don't have long-term data. We're just starting to get that. Next slide. I want to acknowledge everything I've learned from my patients over the last 12 years and during my residency, which has been quite a lot. The way I practice now is very different from how I practiced 12 years ago or 11 years ago. And some of my colleagues that have helped me on the imaging side, and my collaborator in the lab, Michael Gold, where we're really studying the fundamental mechanisms of trigeminal neuralgia that really apply much more to patients with non-classical forms of trigeminal neuralgia. And with that, I'll take any questions, or if I've run over, I'm sorry, and I'm good.
No, you're fine, and I do have actually a few questions for both you and Dr. Brown. So if we can bring Dr. Brown back in. Okay, well, I'll start with the question. There we go. So let's ask this question to Dr. Brown first, and then if you have any other information to add, you can, Dr. Sekula. When in the course of this condition should a patient consider having an MVD as opposed to just treating the condition with medication?
Oh, perfect question. I apologize we didn't cover that. First, one must get medical treatment. And what constitutes adequate medical treatment? My judgment is that one has had a course of one or at the most 2 different anticonvulsants for a reasonable period of time at a dose which is adequate. What does that mean? Not all medication at the lowest level is effective. We don't know the dose that's effective. One might have to titrate the dose up to the point just short of where it causes side effects that are bothersome. If the first medication one tries does not stop the pain or works for a while and then becomes bothersome at higher doses, one can go to a second medication. But my experience is that after a second medication has caused side effects and does not stop the pain, that's an adequate trial of medication. Now, some patients may not tolerate any medication because of the nature of their work. They don't like to be drowsy or non-functional, and that's important. And some patients might react with a allergic reaction to the medications early on and not tolerate. So the short answer is when anticonvulsant medications, which are usual in their use, do not help, or the side effects are intolerable, then one talks about an ablative or decompressive surgery to perform that. One thing is, I have no evidence in my practice that using 2 medications at once is of any benefit, or going to expensive extended release versions of the medication is of any benefit.
Okay, Dr. Sekula, do you agree with that?
My thoughts coincide entirely with Dr. Brown, and I would only add to that that if I believe a patient is a good candidate for microvascular decompression, and generally speaking in my practice, I just want to make this clear, that has nothing to do with their overall health. It has to do with some of the factors I mentioned earlier. As long as I think they've got, say more than 5 years to live, I think they're a good candidate for microvascular decompression. I strongly recommend microvascular decompression as soon as they're ready, because so many patients tell me I, quote, lost X number of years of my life, and I wish I'd done this sooner.
I would add that many of my patients after surgery and off medicine, their comment is that they have their life back. That's an important thing to get back, and that's the goal of each of us that does this surgery, is to give people their life back.
That's what they say, Dr. Brown, every week.
Mm-hmm.
Okay,
it's a wonderful job we have, isn't it, Dr. Sekula?
Yeah, it is. No question. We're very fortunate.
Okay, we have just 2 more minutes, so I'm going to ask another question and give you each a chance to answer. I cannot believe how many times this question came up during the course of your presentation. What do you do if you feel constant numbness, particularly if you're feeling pain through the numbness? So anesthesia dolorosa.
My comment on the term anesthesia dolorosa is we shouldn't use it. It's an antiquated term. It's hard to define. It scares the heck out of people if you use it, because it's something out of like the 1700s. So I don't like to use that term. There are varying degrees of numbness. And as Dr. Sekula said, just because there is numbness doesn't mean that one should not have surgery. Sometimes the numbness can improve, sometimes it can't. So my comment is get rid of that term. There is no diagnosis of anesthesia dolorosa.
Again, I agree with Dr. Brown. That term is antiquated. You really won't find a patient with complete anesthesia. It's always some form of hyposthesia or diminution thing. Certainly, if you're in that situation, you need to find a bona fide expert, neurosurgical expert in facial pain to help you. And there are a number of different treatments that can be used, including, again, it's so nuanced that it's hard to answer quickly, but to try to be quick, there are times, as Dr. Brown alluded to, when more ablation may be useful. There are times when stimulation may be useful. There are times when pumping a medicine into the cerebral spinal fluid to bathe the nerve might be useful. There's a lot of options, but you really need somebody who understands things if you're in that situation.
Okay, thank you very
And
much.
I would add that hopefully that person is one person who can take on all elements as opposed to do one thing and then send you off in another direction.
Okay. Thank you very much. Those were excellent presentations, and I'm sure everyone sees how skilled you are professionally, but what also comes through in all of these presentations is that you're just really compassionate human beings who really are in this to help others. So thank you. And with that, I will turn this back to Allie.
Thank you, Ann.
Thank you, Ann.
All right, thank you very much. I would now like to introduce Dr. Stephen Chang, Professor and Vice Chairman of Strategic Development and Innovation in the Department of Neurosurgery at Stanford University. Dr. Chang will be discussing radiation treatment for facial pain, followed by Dr. Ken Casey, who is Chief of Neurosurgery at Beaumont Hospital. Dr. Casey will discuss other ablative procedures. If you have questions, again, during this presentation, please type them in the box and we will get to as many as we can. So I'm going to turn it over to you, Dr. Chang.
Thank you. I'm going to discuss briefly today the use of focused radiation to treat trigeminal neuralgia. And I'm going to talk about the various different types of machines that are used to do this, but specifically focus on the CyberKnife because that's the machine that we use at our institution that we're the most familiar with. Next slide, please. So the other speakers have already covered the different treatment options on the list that I've listed here, so I'm not really going to go over it. And again, we'll talk specifically about radiosurgery. Next slide, please. The first concept is to understand what radiosurgery is, and I thought I would just have two brief slides discussing kind of the physics behind radiation treatment. So most of the radiosurgery is either by a machine like a Gamma knife or a CyberKnife, and I'll talk specifically about the Gamma knife in a few slides. But the CyberKnife is a linear accelerator, and it generates radiation by accelerating electrons at a very, very high speed, and then the electrons strike a metal plate, and that impact of the electrons on the metal target generates an X-ray beam, which can be directed to the patient. Next slide, please. And this is a picture of what it looks like. You see a radiation linear accelerator, which is that gold tube. It accelerates an electron, which is that red arrow, and it strikes a metal object. And then that generates a radiation beam, which can be directed to the patient. Next slide, please. This is the CyberKnife machine itself. It has several different components. Next slide. The first component is a linear accelerator. It's that rectangular box, that blue and white box that you see in the center of the screen. And it allows us to generate and produce the radiation beams that can be targeted to treat the trigeminal nerve. You also see a robotic arm, which is a device that can direct and point the linear accelerator with high degrees of precision. Next slide. There are camera sources in the ceiling that track the patient and image detectors on the floor of the room that capture the patient position. So this allows us to track the patient with a high degree of precision. So if the patient during treatment were to move, the machine would detect that motion and compensate for that motion when delivering the radiation. Next slide. And then we have software that tracks and targets the radiation. Next slide. And again, this is another picture of the machine showing all the different components together. One of the main advantages that the radiosurgery has when treating trigeminal neuralgia is that the treatment is completely outpatient. There's no hospitalization. The patient is treated in street clothes, and at our institution on the day of treatment, there's not even an IV placed. So the patient drives into the medical center, is treated, and then drives back home. Next slide. This is, I wanted to talk briefly about the Gamma Knife because this is another type of radiosurgery that is commonly used to treat trigeminal neuralgia. The main difference between a linear accelerator such as a CyberKnife and the Gamma Knife is the source of radiation. The Gamma Knife uses radioactive cobalt to generate the radiation, but essentially it's the same concept. You're producing very focused beams of radiation that can be delivered precisely to a target, in this case, the trigeminal nerve, to achieve a result desired, which in this case is pain relief. Next slide, please. So this is a big question, is how does the radiation actually eliminate my pain if I'm a patient with trigeminal neuralgia? And the bottom line is it's not quite exactly understood. We have a lot of information regarding the biology of the radiation on the nerve, but the actual mechanism is not quite understood. I like to think of the trigeminal nerve as a cable wire. So the nerve is the metal wiring. The nerve has a protective sheath called myelin around the nerve, and that's that coating around the wiring. And when you're delivering the radiation, you're essentially delivering the radiation to the nerve to try to damage the actual wiring. You're trying to damage the actual pain fibers in the nerve. And the radiation achieves this over a course of time. Sometimes it can be fairly short, like on the order of a few weeks, and sometimes it can be longer in the order of a few months. It just depends on patient by patient how long the radiation takes to impact the pain fibers. So essentially what you're trying to do is destroy the pain fibers so that the nerve can no longer conduct the pain. Now, the trigeminal nerve carries more than just pain fibers. It carries all the rest of the sensory fibers for the face. So we're talking about touch, temperature, those type of sensations. So when you deliver the radiation, we're trying in a perfect world to spare those functions and just destroy the pain fibers. Next slide, please. So when we target the radiation, we use very thin slice MRI scans to target the nerve. These are the same MRI scans that we use to review and study when we're determining whether a patient is a candidate for microvascular decompression. But in this case, we are using the the MRI scan to identify the nerve and target the nerve. In the case of radiosurgery, we don't necessarily, we're not concerned about whether or not there's a blood vessel pushing on the nerve or not, because essentially we're ignoring that component and we're just targeting the nerve with the radiation. Next slide, please. So how narrow is the radiation beam that we use? Typically, the beam that's used to treat the trigeminal nerve is about a 4 to 5 millimeter width beam. So that's about a fifth of an inch in width. And the actual precision of the beam is 1 millimeter. So you can see on the scale there using the pencils, the beam itself is about the size of a pencil eraser, but the actual accuracy of the beam is less than a millimeter of targeting error, which is the tip of the graphite portion of the pencil. Next slide. This is a close-up of a treatment plan for the trigeminal nerve. So I'll show you a close-up, and then we'll show you a more broader view. So in this close-up, the nerve is the gray line that you see covered by the radiation. So the red rectangle is the actual outline of the target of the nerve, and the green circle is the radiation that's delivered to the nerve. Next slide, please. And this is a kind of a more bird's eye view. In the upper right corner, you'll see, again, a nerve that's targeted with radiation. The two lower boxes show how the nerve is targeted in a three-dimensional view in two other views in addition to the horizontal slices. And the box in the upper left corner, you can see kind of the outline of the patient's head on the computer screen. And each one of those dark blue and light blue lines represents a different beam of radiation coming in from many different angles. And they all focus and deliver radiation to the trigeminal nerve to achieve the pain relief. Now, a question that often comes up is, well, how do we know the radiation is not impacting any of the normal tissue as it travels through the head to the trigeminal nerve? And the answer to that is that we use a large number of beams, typically over 100 beams. So each beam of radiation carries, for example, 1% or less of the total radiation. And so as it travels through your head and goes out the other side, it's not sufficient to damage any of the tissue. However, all the beams travel through the trigeminal nerve. They all focus on the trigeminal nerve. So the nerve receives the cumulative effect of all the beams of radiation, and that is the dose necessary to damage the pain fibers. Next slide, please. Just briefly, a couple of different publications. So as we've accumulated data, we've published our data at Stanford. Next slide. Other institutions have followed along. This is a group out of Taiwan that published their data. Next slide, please. And then we've collaborated with many other centers. This is a multi-institution study paper here focusing on trigeminal neuralgia. And I wanted to briefly go over the results of this data. Next slide, please. So I'm going to specifically focus on one of the multi-institution papers. I think it provides a very broad overview of the results. Next slide. So this is about 100 patients treated in this series. You can see the breakdown between men and women. There was a little bit more women than men. The average age was about 70, ranging anywhere from 40 to 92. The average patient had pain for about 8 years before treatment. Interestingly, we had more patients with right-sided pain than left-sided pain. And at the very bottom of this slide, you can see about 1/3 of the patients that came in for our radiation treatment had prior surgical procedures and had failed the treatment, the microvascular decompression treatment, and therefore we're choosing the radiation as a follow-up treatment option. Next slide. So our treatment protocol is to obtain a thin slice MRI scan. We fit a mask over the patient's head for the treatment. We do some computer planning, and the patient doesn't necessarily need to be there for the computer planning, because once we obtain the images, everything is done with high-speed computers by a neurosurgeon, a radiation oncologist, and a medical physicist. And depending on the timing and how fast you generate your computer plan, you can either treat the patient the same day that they came in for their MRI scans or on subsequent days. Next slide. This is the graph showing the results of this multi-institutional paper. Initial outcome is outcome at the 6-month mark, and you can see that about 2/3 of patients had excellent pain relief, so basically no pain, and then another 24% had either partial pain relief or some pain relief. And so this number totals up to about 90% of patients. So 90% of patients had a response in the first 6 months. Longer term, as you follow the patients out, there is a drop-off. So only 50% of patients still had good pain relief once you got further out at the 3 to 5 year mark. And the simple explanation for this is that as the radiation damages the nerve, your body does what it normally does for any type of damage, which is to try to repair itself. And as it repairs the pain fibers, they can reconnect, and you can have some recurrence of pain. One of the advantages of the radiation treatment is that you can repeat it a second time if the pain comes back, to re-damage the nerves to achieve pain relief. Next slide. So what are the results of radiosurgery? In the short run, 90% of patients that have type 1 trigeminal neuralgia achieve pain relief. It typically takes a few weeks to a few months to kick in, and this allows patients to either come off the medication or lower their doses of medication. And as I mentioned, if the pain does return because the nerve heals, you can retreat the patient. Next slide. Just want to conclude by talking about the one main side effect of the radiation. You know, it's an outpatient procedure, so you don't have any of the surgical risks. But the trigeminal nerve also carries sensory fibers in addition to the pain fibers. And these are the feeling, the light touch, the temperature fibers in your face. And so as you radiate the trigeminal nerve, you can impact these other nerves, the non-pain nerves, and this can cause some numbness in the face. It's not complete numbness, but it can create a partial numbness, and this occurs in about 50% of patients after radiosurgery. Interestingly, the patients with numbness are more likely to have long-term pain relief. It means the nerve has been impacted to a greater degree after radiosurgery than the patients without numbness. And the numbness may not occur right away. It can come on a year later, for example. And if it does occur, it can improve over time. So this is one of the factors that we don't have too much control over. We do know if you have numbness, it is a better result in terms of pain relief, but it can be potentially slightly bothersome to patients after the treatment. Next slide. So to summarize, radiosurgery is a very safe treatment for trigeminal neuralgia. Initial results show that 90% of patients with type 1 trigeminal neuralgia achieve pain relief. We know over the longer term, the pain can come back in some patients if the nerve heals, but you can repeat the treatment. Numbness is a common side effect. But overall, radiosurgery is a good option. We use it at our institution as an initial treatment for patients that don't want to undergo microvascular decompression, or as an option for patients who have failed other treatments. Next slide. So this is a team approach. It takes a large number of people. This is our team at Stanford. Next slide. And we'll follow up after the next presentation. I'll be happy to answer questions. So for now, I'm going to turn it over to Dr. Casey.
Hello, Dr. Casey, you are live. Doctor, we can't hear you. Can you check your microphone real quick? Make sure you're unmuted. No, I'm sorry, we can't hear you yet. Do you mind calling our tech support line so we can work out your...
Dr. Chang, we're going to take some questions for now. So Dr. Chang, first question for you. You briefly did talk about that you can have radiosurgery more than one time. Would you recommend it? You said 2 times. Is there a limit, or it's patient by patient?
That's a good question. So as you do a second radiation treatment, two factors come into play. The first is the results of the overall average results of pain relief the second time around are lower than the first time around. So you're not going to necessarily be achieving 90% success rates the second time around. It's going to be lower, potentially 60, 70% in that range. Still the majority of patients, but not the 90%. And then the second issue with a second treatment is the chance of facial numbness occurring is higher. Because the nerve is seeing a cumulative dose of the radiation. So it's very common potentially to do a second treatment. There are even publications talking about third treatments for the trigeminal nerve using radiosurgery. But again, as you do a second treatment or potentially a third treatment, you'll have lower pain relief results and higher numbness.
Okay, thank you. Just to add on to that question, what is the length of time between the treatments? Like, should you wait a year before you have an additional treatment?
That's also a very good question. Because we know that the pain relief from the initial treatment can take months to kick in, you can't say that a radiation treatment has failed till at least 6 months. So we use at our institution a 6-month mark. If you still have some pain or you still have pain at 6 months, that's when we would offer a retreatment. But we've certainly seen patients who have shown up for follow-up at 4 months and still have had some pain, and then at 6 months have had no pain. So we have learned that you have to wait long enough for the radiation to have an impact on the nerve. But the short answer to the question is 6 months is what we typically use.
6 months, okay, thank you. How do you focus just on the pain fibers? You talked about how it's a very, very small beam of radiation, but how do you focus on just the fibers that are going to impact the body with pain?
Yes, and that is the difficulty with the fact that you have pain fibers and the sensory fibers. One cannot separate them out on the nerve. They run together. When you look at the MRI scan, you cannot see any difference between pain fibers and the sensory fibers. So you end up treating the whole nerve with the radiation. And what you're hoping for is that the pain fibers, which are typically are smaller in size than the sensory fibers, you're hoping that the radiation preferentially damages the smaller pain fibers and spares the larger sensory fibers. But there's no way anatomically on an MRI scan you can separate them out. So essentially the whole nerve will be treated.
Okay. You did mention facial numbness, and you said that can happen later on. So a patient could wake up from the procedure and not be numb, and then a couple months later they could feel numbness?
That's correct, because similar to the delayed time course in terms of achieving pain relief, where it can take several months for the pain relief to kick in, the numbness in the face can also take a few months to kick in if it occurs. So typically we don't see it right away, and there are patients that can have complete pain relief, let's say at 6 months and no numbness, but then at 12 months or 2 years later, they can have some numbness kick in at that point. So it is also a delayed response. It doesn't necessarily need to occur with the pain relief.
Okay, thank you. Another question, would you recommend doing like an MVD first or other surgical procedures, or do you generally recommend starting with Gamma Knife or Cyber Knife? What's your preference?
That's a great question, and I think that's a dilemma that many patients have, because they oftentimes are told they're a candidate for both options. So how do you choose? And I think many patients struggle to make that decision. My practice is half microsurgery and half radiation. So I actually will offer both options to patients if I think they're candidates for both options. Typically in younger patients where we're looking for decades of pain relief, I typically favor a microvascular decompression. However, in patients that have either failed that treatment, they've had a microvascular decompression already and either got pain relief for a few years or didn't have any pain relief, those patients may be reluctant to undergo a second procedure, surgical procedure, and may want a non-invasive treatment. And then you have another class of patients that either because of other medical issues, medical comorbidities, medical problems that preclude them from having a general anesthetic for the microvascular decompression, they would be good candidates to go straight to radiosurgery. And then as patients become older in age, the risks of the surgery, a microvascular decompression surgery, go up. And then there's a much stronger shift toward radiosurgery as being a primary option.
Okay. Thank you so much for answering those questions. I believe we have Dr. Casey on.
Okay.
you hear me
Go ahead,
now?
Doctor. Yes, we can hear you. Go ahead, Dr. Casey.
I think well, my wife must have gotten on and blocked me. She usually does. At least when I'm talking to her, she always blocks me out. So that's part of the problem. Okay, we've been talking for a couple hours, and just want to ask people, I'm going to turn this around a little bit for the audience. I'll buy, Dr. Myers mentioned at the beginning, or Mr. Myers did, that he's going to give out books to people who got picked on the little thing for the survey. So those of you who can tell me what this picture is taken from, you can see my tie. A little bit of the background of the picture, especially what's very important is this picture is essentially a microcosm of this whole organization. Because as you know, this is a worldwide phenomenon. This affects somewhere between 13 and 23 per 100,000 worldwide. I was recently in Ethiopia, and I was talking to some of the surgeons, and they said, we've never heard of it. When we started asking the patients and leaving them some messages, that McGill that Dr. Brown so eloquently referred to, they found within a year that they had 5 or 6 patients, and they were stunned. And the same's true at Queen Square of England. They thought children can't get it. We left it with the Children's Hospital. A good friend of mine, Dr. Pang, is there, and they all of a sudden started figuring out that they must have face pain patients. So it's a worldwide phenomenon, and both the FPA and we, the MAB, we want to work with your doctors worldwide. You don't always have to come to us. We want to work with you. That's what this MAB really does, is we provide our expertise for as many people around the world as we can reach, because you patients present us the seeds that we need to investigate. Some of that information is blooming, as you've heard so far, and you'll continue to hear as we go on in the morning. But the fertilizer experience that gets this going is our fertilizer. We're the ones who have the experience, so we can work with your doctors and make this a worldwide thing. But as you've already heard, first of all, we don't always agree on the diagnosis. And secondly, there's the issue of what do you do with the patient? So as Dr. Nixdorf, I think, referred to very early on, and I totally agree with this, is we treat the patient. We don't treat ourselves and give the patient what we have. That hammer that Dr. Brown referred to, it really should be a toolbox. And you should think that the place where you buy your toolbox is always having a sale. So you should be going down there frequently looking for more tools. And that's what this FPA and MAB do together, is they do just that. So on the next slide, which will come up in a second, when you have face pain, all you can think about is your head. I mean, that's dominates your entire life. In a recent publication, the person wrote about the fact that there's 2 times in your life. It's before pain and after pain. And before pain, you can't even remember anymore, except as a distant, missed memory. But after pain becomes the whole thing. I mean, we find when we examine patients that this dominates. There are 5 things the nerve does. And these are important in determining some of the procedures we're going to talk about in a second. But the brush of a light kiss across your forehead for light touch, and the fact that if you have the child bump your head for pressure, the wind on your face, which is part of the vibration, the air conditioner cold, and then a pin, those are the 5 things your nerve does for a living, and how they do them and how they're affected affects us and affects you and how we're going to get this to work down the road. So I think that's an important distinction, that we have to not just say you have face pain or you have trigeminal neuralgia or you have what was referred to previously, I agree, anesthesia dolorosa is an alternate deafferentation pain where the nerve has been injured either on purpose by one of us or an accident or accidentally another way where it has disease. But the point is that that tells us how much of the nerve is damaged and what can we do to help about it. Because the issues with this are very important. So let's go to another slide. Next slide. So you can have the gamma knife, as you heard from Dr. Chang, or the cyber knife. Unfortunately, it has its side effects. This is some of the early work done in New York with the gamma knife, a little tough on the brain. I would pose a question to him. I guess we're allowed to do that, but Ali will slap me down if not. But do we really think the gamma knife and the cyber knife are the same? The precision is a little bit different. The fall off, meaning the amount of radiation that stays away from other vital structures, is different. And so I just bring that up as a question. But in the next slide, the problem, as we said, with diagnosis is deciding whether you have it. What's interesting about these procedures is the MVD and certainly gamma knife, cyber knife, they rely on a really precise diagnosis, as Dr. Sakula very nicely outlined. And in his case, not only a precise diagnosis, but a precise pathology so that the MVD has a very specific application. We may quibble about whether you can do some other things to the nerve while you're in there to help it, but the issue is diagnosis. With these procedures, the ablative procedures, first done in the 30s, first of all, they didn't have any of that imaging. And secondly, they had a much more functional approach, so to speak, to pain, saying, well, you have pain. If I injure the nerve, pain will go away. In fact, there was a long period of time in Philadelphia where I trained briefly, where they cut the nerve, which I hear from patients even today. People say, well, can't you just cut the nerve and I'll be better? I can, but it'll be like the guy who got his leg cut off who says his toe hurts every day. They used to inject alcohol into the nerves, and certainly as an Irishman, I support the use of alcohol any way possible, but that one didn't work. It created too much damage, and it really made people worse. Next. So we have to decide, what do we do? Well, if you think of your surgeon as a marksman, then we can talk about some of these procedures. Next. You can take a needle. Now, I exaggerated. This is a little needle, and some people have been using Botox on the face and so on, and we're not going to talk about that today, both for lack of data and lack of time. But our needle is substantially bigger. It approaches the size of the beam that Dr. Chang referred to in the radiosurgery. So I can remember when I first was learning with Dr. Tu at Cincinnati about one of the procedures we're going to talk about in a second here, radio frequency. They did the patients somewhat conscious. They got an injection, the patient went to sleep, needle went in, the patient was awakened with the needle still in. And they were asked, did they have face pain after a certain portion of the lesion was done? And I can just remember so many patients saying to me afterwards, Doc, of course I had face pain. It was a giant, and then the word F was used a couple of times, needle sticking out of my face. Of course I had face pain. So I tend to do all these asleep for that reason. Next slide. But what is it that we do? Well, you talked about the MVD, and I think they briefly mentioned that you have to make a hole in the head. I trained with a resident named Frank Vertosik, and Frank had an interesting book, if you want to read it. It's called When the Air Hits Your Brain. It was his assumption that it's never quite the same. And maybe that's the origin of the term airhead. But in any case, some people don't like the idea of somebody drilling a hole in their skull, even if, as Dr. Brown said, the nerve's in exactly the same spot. There's no exploration involved. It's a very straightforward procedure in the hands of an expert. They just don't like the idea. So in that effort to match our offerings to what the patient wants, these needle procedures have become far more polished. So with the patient asleep, needles introduced into the cheek, into a naturally occurring hole in the skull base. And as you can see in the slide in the center, with the two depictions from Tony Kaufman in Canada, the needle comes in and then the balloon in the lower picture is inflated to squeeze a nerve as one of the examples. In the picture on the far right, that's a glycerol. It's a smaller needle. And in the middle, you see what the balloon looks like. So what are these procedures? How could you group them together, the so-called percutaneous or through the skin procedures? Well, in one of them, you bathe the nerve with glycerol. In one of them, you squeeze the nerve with balloon. And in one of them, you heat the nerve. And the issue has always been a debate about, well, how precise can they be? And I think we're past those days. The problem with the chemical, the problem with the heat is it doesn't know not to go here and not to go there. So that so-called ability to avoid certain complications is really reduced in these procedures. When they're done properly, you can still get some side effects. In the next slide. So glycerol is a chemical. You put it in. It's unfortunately much the same as a radiator fluid. In other words, it has an alcohol moiety, which partially damages the basement membrane of the nerve, and therefore it works its effect. To no surprise, it takes a little while. So people awaken from these procedures, because the question was asked about MVD, what to expect, except for the fact that your face hurts from the needle. It may not have started to work yet, because the chemical has to have a little time to work its magic, if indeed it's going to do that. In the next slide, you get this sense of fullness oftentimes after any of the procedures, but I've found it more so after glycerol. A patient tells me it just feels like their face is swollen or full. Now, it can be swollen from a little swelling in the cheek, but it's a very common complaint. Next. Now, Dr. Tu, who is an expert on the board, really popularized this idea of, well, I'll put the needle in, and in the next slide, I'll then deliver an electric current to the nerve. Next. And the electric current will affect the way the nerve functions, predominantly by changing the proteins. So if any of you have cooked steak, and this is one area where I try to be very careful about this. When you cook steak, it starts out pink all the way. If you cook it nicely, you get a little bit of color change on the outside, and the middle stays medium rare as people like it. But if I cook steak, sometimes I really wind up with a char burger, because I either get distracted or I'm looking off in the distance and the steak's busy cooking away. Unfortunately, for radio frequency, for glycerol, and next slide, the balloon, we see that that's a problem. Now, there are side effects with all these procedures. Certainly, we mentioned some of the side effects with radiosurgery briefly, and we'll come back to them. Pretty much 100% of the patients with any one of these three procedures has a sense of numbness or loss of sensation on the side we worked with immediately. And in the case of the balloon, where we're squeezing the nerve, also a sense of chewing difficulties. That can also happen with radio frequency. The other side is that most patients will tell us that they have a sense that their eye feels a little dry for a day or so, but that almost always clears up. And then the difficulty has to do with the application of the pressure. For example, in the case of glycerol, if you put in too much, patients will get nauseated. You have to sit up as one of the technical aspects, or it'll spill out onto your brainstem. So you go to sleep in the standard fashion, but then you're sat up during the case for the remainder of the procedure. In the case of the balloon and the radio frequency, if you squeeze for more than 2 to 3 minutes, according to the American authors, you have a much, much higher chance of permanent numbness, probably as much as 16 to 37%, depending on which series you're looking at. In the case of radio frequency, a lot of people keep looking at the temperature. You're heating it. Remember, this is being Celsius now. You're heating it close to boiling. You're heating it to 80, 85 degrees. And those degrees, the higher they are, the more nerve damage, which is good. The higher they are, the more chance that the damage will actually flip over and be uncomfortable for you, called permanent dysesthesia. But in each of the procedures, glycerol, balloon, and radio frequency, a certain amount of numbness has always been equated with longer pain relief. Briefly, to end up with how long do they last? pretty straightforward. They last about 3 to 5 years on average. So unlike the MBD that you heard about that goes out a little longer, and at least at our institution, the University of Pittsburgh, Dr. Lunsford, I think, recently published we had the first Gamma knife in North America, that roughly 44% of the patients needed retreatment by 5 years. So all of the procedures except MBD seem to have a little bit earlier recurrence rate as the nerve pays more attention. Last slide. And regroups. But our goal, both the MAB and the FPA, is to take somebody who feels uncomfortable, like the fellow on the left, and get you to be the right. Now, however we have to do that is more about you than it is about us. But together, we're getting there, and we just need to keep going. So you use our fertilizer, you keep bringing us the seeds to make us look harder, and we'll move forward. Thanks for your attention.
Thank you, Dr. Casey. We just have about 1 minute, so I just want to ask you one quick question. When should you try ablative procedures?
I think very much like Dr. Sakula said, I think we agree the MVD has come forward as probably one of the longest lasting procedures. So in a medically qualified patient, that ought to be your first choice. But as I just said, I'll use an example. I have a fellow, I've been seeing him now for 10 years. He's a violinist out in Denver. His face pain's on the same side that he happens to put his ear against the violin, and he knows he would like to have an MVD, but even that 0.5% risk that he'll have a hearing change, he said, I can't do that. So it's got to be patient-driven, not doctor-driven. When you should do it, I think the earlier you get face pain taken care of, just like back pain, foot pain, and appendix pain, is better. I think, like Ray alluded to, I'm not as convinced that we need to put people through medications. Once they fail 1 or 2 in as little as 6 months, it's time to move on, not keep the pharmaceutical industry making money and the neurologists pushing pills.
All right. Thank you so much, Dr. Casey and Dr. Chang. Thank you both very, very much. All right. Right now, we have a brief presentation from one of our sponsors, Valley Health.
Hello. Thank you for the opportunity to speak to you today. I'll be speaking to you briefly about gamma knife radiosurgery for trigeminal neuralgia. My name is Anthony D'Ambrosio. I'm a neurosurgeon, and I'm also the co-director of the Valley Gamma Knife program. I focus my practice on trigeminal neuralgia patients, and specifically, I help them by performing either microvascular decompression surgery when necessary, or gamma knife radiosurgery if indicated. Gamma knife radiosurgery specifically is a minimally invasive or non-invasive outpatient treatment for patients who are failing medical therapy, either because they're having side effects or the medications aren't holding their pain and they're breaking through. The key thing to understand for patients who might be breaking through traditional first-line medication therapy is that gamma knife radiosurgery should be considered, or at least discussed, as a potential option to help them recover and maybe even reduce their medications and be pain-free. With respect to the Valley Gamma Knife Center, we were the first gamma knife center in all of northern New Jersey, which has given us a vast experience in the trigeminal neuralgia world. We've treated hundreds of trigeminal neuralgia patients successfully. We've also treated nearly 1,000 different types of patients on the machine for other pathologies as well. One of the key things for people to understand about the gamma knife is it doesn't work immediately. It takes a little bit of time. For patients with classic or type 1 trigeminal neuralgia, it can take upwards of 7 to 8 weeks before patients see the positive effects. And for patients with type 2 trigeminal neuralgia or atypical trigeminal neuralgia, it can take anywhere from 11 to 12 weeks before patients see the positive benefits of gamma knife for trigeminal neuralgia. At our center, we have a similar table of demographics. Our patients look the same and feel the same as most other national and international major centers. We tend to see more females than males, so more women than men. We see a little bit more right-sided pain than left-sided pain. The mid and lower face tend to be affected a little bit more often. Patients that we treat tend to be more typical or type 1 with more severe scores, and the majority of them have not had prior interventions. The Gamma Knife machine that we have is called the Icon. It's the latest machine that Elekta produces. And the beauty of that machine is that they've added the capability of mobilizing the patient so that they can't move with just the mask as opposed to the head frame. I tend to be more traditional with Gamma Knife for trigeminal neuralgia. I still use the traditional head frame, but the mask can be used for other indications. The Gamma Knife is a wonderful machine with very few moving parts and pieces, so the quality assurance is high and the treatment is very accurate or pinpoint because there's about 200 beams of cobalt radiation that are painless that all converge on the trigeminal nerve to give us a very focused dose of radiation using an MRI to find the nerve and the vessel that could be touching the nerve. We call this our target. It's very straightforward and very accurate to be able to treat the trigeminal nerve with a very high degree of certainty and safety. Gamma Knife for trigeminal neuralgia, in summary, has a very high patient satisfaction because the treatment's minimally invasive. There's no blood loss. It does not require a breathing tube. And in our center, it's actually not even done at the hospital. We have an outpatient center where it's done, which in COVID crisis is very relevant because we're able to separate our patients from the main hospital. The history of the machine is long, greater than 50 years of Gamma Knife treatment, although the computers have evolved over time. At the end of the day, the treatment's the same, and we know that it's safe and effective. It can be used after patients fail medical therapy as either your upfront surgical treatment or as a second treatment after some other treatment fails, like microvascular decompression. And for patients who have had a good positive result with first treatment, Gamma Knife can be considered if the pain comes back as a second treatment option. Our team has been around since the doors have opened. These are our doctors. We have a very stable staff. We have great nurse navigators, great physicists, and great administrative support at the Valley Hospital. Like the Facial Pain Association, we have a website for frequently asked questions at valleygammaknife.com, or you can reach out to us at 201-431-8434. Thank you for the opportunity and enjoy the rest of the conference. Have a great day.
Thank you from one of our sponsors. Now I would like to introduce Megan Hamilton. I will turn it over to you, Megan. Now I'd like to introduce Megan Hamilton.
Thank you so much, Allie. I'm Megan Hamilton. I am a director at the FPA, and I am what I call a TN mama. My daughter, Katie, was diagnosed with trigeminal neuralgia at 11 years old, and later with geniculate neuralgia also. We had to wade through so much decision-making about medications and doctors and many more doctors and new medications and surgical options and ultimately 5 neurosurgeons before she had her second and successful MVD. She is now 7 years past that and doing very well. And I now head up also a group on Facebook for the parents of kids with trigeminal neuralgia and facial pain. So today we're going to talk about decision making now that we've given you all of this information. And I'm joined today by Dr. Mark Linsky, who is the professor of neurosurgery at the University of California, Irvine, and by Dr. Richard Zimmerman, professor of neurosurgery at the Mayo Clinic. And our session is going to be a little different. We'll have a discussion together about how to do this and how to make decisions, what information you need, and things like that. So with no further ado, let's move on to some of our questions. We have everybody here. I see Dr. Zimmerman, but I don't see Dr. Linsky. Hello, Dr. Zimmerman. Thank you for joining us.
Hi, good morning or good afternoon, depending if you're on the East Coast or West Coast. But thank you for having me.
It's still morning for me. I guess it is afternoon for me. And do we have Dr. Linsky?
I'm here. I'm not sure why it's not showing up.
I don't know why I can't see you either, but I can hear you, so that part's good. Okay. Well, I'm
click
going
your
to
video
move on
button.
and they get the camera thing fixed there for us. So my first question is, there's a lot of debate in the facial pain community about when to consider changing your treatment protocol, especially because fibromyalgia and related conditions can give you long stretches of remission where you don't have pain, or you might be well managed by medications. So do you stay there? Do you continue changing? And I wanted to get both of your opinions on that. Dr. Zimmerman, if you could start us off and let us know what you think.
Sure. Again, thank you so much for having me. I guess the first thing I would say is it's all about quality of life. So as you assess your condition, you're either stable or having exacerbations or are pain-free. You really have to think about, if I'm happy where I'm at, that may be good enough. And is the quality of my life what I want it to be? And is it impaired by my medical condition, by my facial pain? If you're okay and everything's copacetic and my management currently with whatever you have is good enough for you and you're happy, that's great. But if you're dissatisfied, and obviously if you're in pain, then it is time to consider a change. And no one's saying that you have to make a change or being forced into a change, and you still don't have to be forced into surgery. But if its quality of life is not where it really could be best, then I think it's a time to think about, do I have an option? Should I seek either a second opinion or go from what they recommended from one medicine to the next medicine, or do something differently, really have this surgery I've been putting off for a number of years, or because I'm afraid or because I don't know. And there are many pathways to changing this. There are second opinions. You may already have an expert professional that's helping you manage your pain, and then you talk to that person about changing. But it is the quality of life. I guess I'd try and summarize the answer into that level of assessment.
Yeah, I think that's a really good point. I know we had to look at that for our daughter when she was on medications when you're that young, and think about, is this working for her quality of life, and also long-term quality of life. And I
Exactly.
Dr. Linsky, can you also chime in with that?
Yeah, sure. We're trying to work on the technical issues with the video. So Megan, just repeat the question real fast just to make sure I'm focused and specific.
Absolutely. Given the debate in the community about when do you consider changing your treatment protocol, especially because you can have periods of remission, you can be well managed by medications. When do you think about something else?
Well, I think the answer is very different for different individuals depending on their circumstances. If you're somebody who's near the end of your life and you're trying to make it to the finish line, that's a very different situation than somebody who's young and who is having problems with performance on the job and who's have problems learning or their education or setting their life track ahead of them, or even working in interpersonal relationships and developing them. Those are totally different circumstances. Somebody who is already had their education, has a stable social structure around them in terms of their life relationships, and is doing reasonably well on medication, can certainly afford to go much longer than somebody who knows that this is a progressive syndrome, knows that this is going to fail, and is starting to have trouble moving forward with positive life choices and success. In those patients, they have to move forward sooner. I would also say that we have a couple other problems that patients have to seriously consider. One is that the people who are prescribing these medications initially generally tend to be neurologists, and that's fine because they're very experienced with these anticonvulsant medications. But the unfortunate problem is that most neurologists use these medications for a condition called epilepsy because they're seizure medicines. And the paradigm that they're taught in neurology for epilepsy is that you are not medically refractory until you've maxed out on a dose of at least 3 anticonvulsant medicines. And so the tendency is to just go medicine to medicine to medicine, cocktails, combinations, etc., because that's the paradigm that they're used to with epilepsy. There's no evidence whatsoever that that paradigm makes any sense for trigeminal neuralgia. In fact, I would agree with Dr. Brown earlier today when he said that if you have one main frontline treatment, Tegretol, Trileptal, Neurontin, or pregabalin, and you've been able to get to an adequate dose without toxicity or side effects and you fail, there's very little to be gained by adding additional agents, switching agents, going to longer acting agents. It's time to make a change and decide what's going on, what's best for you. The other thing I'll point out with these medicines is their effects on you are incremental. You keep increasing the dose a little bit by a little bit by a little bit, and you don't realize how severely you're being affected because you're no longer comparing against yourself before you started the medicines. You're comparing against yourself how you were on the last dose. And as that starts to happen, you don't quite realize how much of a fog you're in and how much your judgment and thinking and memory and learning and focus and concentration are starting to be impaired. And this creeps up on you. And I'm sure Dr. Zimmerman would agree, most patients, once you get them pain-free after surgery, if you're able to do it, and they get off their medicine, will tell you when they come back to the office, I had no idea had no idea how much these medicines were affecting me. I sure wish I had done this sooner. Does that answer your question?
Absolutely, yeah, and I have to agree from a long point of view. Honestly, our daughter was 11 when she was diagnosed and almost 14 when she was finally pain-free and off medications. And I thought she had just been going through teenage years. And when she started really cutting off the medication, all of this personality came back and talkativeness and hyperness and happiness that hadn't been there. And I realized that was a really big hindrance for her. It was a big difference. So I think you're absolutely right on the medication.
Megan, I'm going to log out and try to log in again and see if I can reconnect the video. So I'll be back.
Absolutely. We're going to keep going, but we'll bring you back in. Okay. Our next question is, if I come to you, Dr. Zimmerman, as a patient, and I'm discussing with you the possibility of surgery, how can I best be prepared to help you help me? You know, what is it that I can come in the door ready to talk about with information or whatever to present to you so that you can best help me?
Well, I think the first thing I would say is let me understand well how this is affecting you and tell me the experience you're having with this and how much it's impacting your life. Because the most important thing the first time you come in the door is we have to confirm that it's the right diagnosis. We do need to know that it is TN and not a different type of facial pain syndrome or craniofacial headache syndrome. But assuming it is TN, and whether it be TN1 or TN type 2, you have to feel confident that the person you're talking to about surgery is a surgical expert. Because one of the biggest problems you'll have is you'll go to someone to talk about surgery, but that patient does, quote, cranial surgery, or they do it. I do MBDs, so to speak, and I'll put that in quotes, because many neurosurgeons are, quote unquote, trained to do MBDs. That does not mean that they're a specialist in MBDs. So in preparing yourself to help me help you, I would suggest to you that you make sure you go to someone who is well-versed in trigeminal neuralgia, the scope of the disease, the time course of the disease, how it impacts the patients. And then obviously for all surgical issues, you want to go to someone who's an expert. You don't want to put someone who's finished flight school into the space shuttle for their first flight. If it was your brain, you wouldn't want this to be the person's first MBD of the century. Oh yeah, I've graduated, I trained, and I did a lot of MBDs, and here's my first one on my own. You really should see someone who is qualified as an expert, who, for lack of a better term, has a good reputation, who has had good outcomes that other patients can, quote unquote, attest to. And resources like the FPA, TNA is a great place to find experts. Preparing yourself to help me help you is for you to be knowledgeable about those things. Once you get to that stage and you're at the door of someone who is well-versed in treating trigeminal neuralgia and you're looking at surgery, be prepared to ask questions and have them answered. If someone says, oh, I have 15 minutes to spend with you, you have TN, I see the vessel here, it's time for surgery, I'll book you on Tuesday, it's time to walk out the door, because honestly, we see patients who have their surgery scheduled before they're interviewed in places that simply want to get the surgery done and go on. And that's not the way to take care of someone who's been suffering with this condition and facial pain. So prepare yourself by being ready to ask questions. simple questions about the surgery, the surgeon's experience. What should you expect from surgery? What kind of a discomfort am I going to have after the surgery? What's my recovery going to be like? How long will I be in the hospital? If you can't get answers to all your questions and your family members can't get answers to their questions, then it's time to keep looking. In getting back to what can you do, I would say prepare your questions. And there's Dr. Linsky.
There he is. We got him back.
I regret it, but I'm here.
Woo!
Hi, Dr. Zimmerman.
Hey, Mark, how are you?
Okay, well, Dr. Linsky, let me pose the same question that Dr. Zimmerman just answered for us, which is, if I come to you to discuss the possibility of surgery, how can I be best prepared coming in the door to help you help me? What information do you want? What can I do to make that the most productive I can?
Well, first of all, if you've had procedures before, it's very important to collect the reports of those procedures so that they can be reviewed. Saying that you've had a prior MBD, saying that you've had a prior gamma knife, whatever, they're not all equivalent. And in particular for MBDs, you need to be able to read and see what the other doctor did and what they saw and what they found and even how they closed up, things like that. So details of the procedures are really important. I like to have a patient have a cranial nerve protocol MR done, which is it's already been described in the earlier talks, volumetric T2 acquisition with submillimeter slicing, and that, depending on the machine, can be called a KISS, a Fiesta, a fast echo, depending on whether it's a Philips, GE, or Siemens for the machine that's doing it. That helps tremendously. But really what it boils down to is an understanding of the patient's circumstances and their life goals. I mean, what is their family relationship? What do they see as their timeline of wanting to have control of this going forward? What is the impact of the disease and the medications having on their job performance, depending on what they do and what their goals are for that? What is its impact on their relationship with their spouse, with their children? What risks are they willing to take given the fact that they are often part of a social unit, and they're not making decisions just for themselves. They're making decisions for their families. They're making decisions for their spouse. They're making decisions for their children, and you need to put that in proper perspective because there's no one size fits all, and there's no one treatment recommendation that works for everybody. There's a right answer for you, given your own goals, priorities, and your own risk assessment and risk tolerance. What I often tell patients is that there's no such thing as a course choosing between a course that's safe and a course that's risky. Every single course ahead of you carries risk. And for a progressive syndrome like trigeminal neuralgia, doing nothing, depending on how young you are and how it's affecting your life, could be the riskiest choice of all. But people also tremendously differ in their risk tolerance. I like to use the analogy of money. Some people will only put their money under the mattress. Some will bury it in the backyard in a coffee can. Some are willing to put it in a savings account, but only up to the FDIC insured amount. If not, they're moving it to the overflow to another bank. Some will go into the stock market, but only in balanced mutual funds. Some will invest individually in stocks. Some go on to junk bonds and things like that. Everybody's risk tolerance is different, but the money analogy also goes well in understanding the benefits for a given level of risk. Open surgery with anesthesia, hospitalization, recovery, and risks also carries the greatest possible, both short-term, immediate in the recovery room, and long-term for the rest of your life benefit. So when you're going to get to the point where you're ready for surgery, it's going to be an individual choice. Dr. Janetta told me during my 7 years with him is that you never want to talk a patient into surgery. They'll know when they're ready. Just make sure that they understand what's going on. And that, I think, weighs into another critical thing. The time to talk to a surgeon about the options you might have for surgery is not when you're in extremis, in desperate, in severe pain. It's not when you're overwhelmed with the medicines and you can't remember what you just heard, you can't learn, you can't focus, and you're falling asleep in the doctor's office. It's like estate planning. the time to do it is early in your life, so that when you get to the end of your life, or in this case, to the time when you're ready for surgery, you already have your plan laid out, and it's just a matter of implementation and pulling the trigger. So see a surgeon early. You're not committing to surgery. You're getting information, and there's no downside to information. And getting that information when you can best understand it, best put it in perspective, and best fit it in a non-time compressed manner to your life planning is the time to do it.
Right. And for full disclosure, Dr. Linsky is the one who did my daughter's second MVD. And I don't know if he remembers this, but we came to him very informational. We want to talk to you about this. And at the end, we're like, we're going to go home and talk about it more. And only called back later to say, yes, we're going to do this in 2 months, because that's what was going to work for our family. And we were in a place that we could do that because her pain was still pretty much managed with medication. We didn't have to make an urgent decision right now to fix this right this very moment. And I think that was really important for our own peace of mind in proceeding with what we were doing too. We could be very well thought out and reasoned and take a deep breath before we jumped into that. Dr. Zimmerman, do you have anything to add?
No, I think it's pretty much right on the same wavelength as Dr. Linsky. I mean, it's just like if you're taking medication for anything, you don't want to wait till the medicines run out and you're going to call for a refill and expect to get a response and a refill immediately. You don't want to wait for the last minute to decide you need surgery because now you're suffering and the medicine's not working. It is always a good time to know all your options. The better educated you are about your condition, the better educated the family is about the condition that you have, the better you can make good decisions and good choices. And certainly, I think all of us, since we feel that there is a cure for this condition, not a management protocol, which is medication, but a cure to stop the condition with surgery. I think a lot of us, obviously the surgeons have an admitted bias, but when we feel that there's a cure as opposed to a management option, we think that you should consider the cure early on.
Wonderful. Yeah, I agree for my daughter at least. And also I wanted to put in there, when you're going in to have this first consult with neurosurgeons, it can be really intimidating as a layperson to walk in there and be getting all of this information about subjects you previously knew absolutely nothing about. And I came in with lists of questions, and Dr. Linsky can vouch for this. I would always come in with my notebook and many questions, many questions listed out, and be asking them one after another and taking notes. And I liked having, anytime I could, have someone else there with me to make sure they were catching the pieces that I might not be catching. We could all talk about it afterwards, my friend and I, or my husband, in order to kind of like, did you get that too? Did you understand what he was saying there? Did we both understand that the same way? So I think that's a really valuable thing to do for anybody considering these surgeries.
Yeah, I think that's an important point to make, both what Mark had said and what you just said. It's even more so if the patient is already taking medications, they are impaired to the ability to recall and comprehend what's being discussed. Even if they take notes, maybe in a fog. So have an advocate with you. Patient advocacy becomes extremely important for any surgical procedure because during your recovery, during your transportation, during your management of anxiety, and so many aspects are surrounded by the support system that you have. So having someone to take those notes for you, if you're the patient with the condition who's on the medications, you're not really necessarily always all there. So to taking those notes, ask those questions with someone who can help you.
Absolutely.
Two very good points, Megan. The first is that studies have shown that the stress of being in a physician's office, even if you're not on medication, let's say for surgical consents, that the average patient only remembers 50% of what they're told. So having a second person there with an additional accessory RAM to help remember is exceedingly important. And in fact, for consents, I insist upon it. The other thing is that a good consult, you'll know you're talking to a surgeon or even a non-surgeon dealing with trigeminal neuralgia. If your first consultation is like going to class, it really needs to be an educational session. And it can't just be them saying, I know what you've got and this is what you should do. It should be laying out what the natural history and the pathophysiology of this condition are, linking it to your circumstances, goals, and priorities, and then in a rational, organized, schematic way, going over the options. We also make sure that every single patient at their first visit is fully connected with all the information that we value that's out there. So some of them come to us because they were sent by their doctor or their insurance company. Some come because they were on a Facebook support group, but not everybody is necessarily connected with the national nonprofit organization in Gainesville. Not everybody has had access to their literature in terms of paperback publications. Not everybody knows that we have a face-to-face Orange County support group if you don't like Facebook and you want to be face-to-face in our county. So we make sure that they're all connected and hooked into those things. And then finally, you'll find that the most expert physicians dealing with this have a team around them, and that's there for many reasons. But one of them is you don't want to necessarily dominate your time with the physician taking on all the basic information. You want that basic information to be able to already be done and present before the physician comes in, so that you can really focus on what's really important, the education, the counseling part of the visit, rather than having the doctors asking you what your allergies are and what surgical procedures you've had and what your past medical history is, et cetera, and so forth. And Dr. Zimmerman, I'm sure, has it set up the same way I do. My PA's been with me for over 5 years and probably knows more about trigeminal neuralgia than most board-certified neurosurgeons. And my nurse coordinator has been handling the phone as well as coordinating the care and the testing for my patients for 8 years. And these are invaluable pieces that need to be there for you to be able to focus and spend your time on the quality issues with the consultant.
Mm-hmm. Absolutely. We have come to really rely on and enjoy your staff because we often wind up talking to them. And I think that's wonderful when doctors build that around them. It helps a lot.
Absolutely true. And Mark, to the point of having a team around you, the other aspect that's a good question for patients to ask is, what is your protocol? How have you set up special care for your TN patients? So whether you have a team around you, like you said, allied practitioners, advanced practitioners that know about TN, that can answer a lot of questions. What do the nursing staff on the floor know about TN? How educated is your floor unit for taking care of these patients and managing them safely in the hospital and getting them in and out effectively, efficiently, and safely? The team approach is extremely important to good care of the patient. Their hospitalization is such a brief period of the time that they spend suffering with disease and searching out the answers. But that's probably the most critical point, is to make the right decision, to be informed well with some support system around you, but have the team that's available from the healthcare provider. So when you do have questions or when problems do arise, there's always someone there available. There's not one person that's going to be always available. But if you build a team around the program that you have for trigeminal neuralgia, then there's always someone that can answer something about it. Even if it's not a primary member of your team, all of our staff, the PAs, know the trigeminal neuralgia practice well. And therefore, it pretty much doesn't make a difference when you call about tapering your medications, coming off of them after surgery, surgical wound care. It really makes a big difference that there is a system built around your trigeminal neuralgia practice.
Absolutely. Absolutely. And I also wanted to mention for those who are watching that before into the doctor's office, I had done a lot of reading. I think it's one of the wonderful things about the FPA is the website, the articles that are available. And so I had some knowledge of the terminology that was going to come out. I had some basic knowledge. And so I just really encourage that too for anyone who is going into these appointments to go learn some of this stuff, get familiar with it. It really does help. I want to ask you, one of the things that we struggled with is we had some doctors who were telling us, no, surgery is not an option. Others saying, yes, it is, absolutely. Or some would say, well, I'm willing to try. And we very much encourage at the FPA people to get a second opinion. But what do you do when you get two opinions that don't agree or more that don't agree? How should the patient approach that in their decision making?
Well, the first thing is that the device. You really shouldn't be having a non-surgeon that surgery is not an option. That's rather somewhat arrogant of that person. You really need to talk to a surgeon about that, and one that's very experienced in doing these sort of things. That being said, it is certainly possible and highly likely that good, well-trained, good, smart surgeons who are not bad people, who are trying to do the best for you, can legitimately disagree. And that's fine. What you need to understand is, why do you believe what you believe or say what you're saying? What are the reasons behind it? And then research the reasons behind it, and don't be afraid to get additional opinions. You don't necessarily want to be searching out the person who says what you want them to say, because then you're going to have your surgery done by somebody who does one of these every 3-4 years, who says they have a 100% success rate and have no complications. And that may be what you want to hear, but that's not very likely if that's the circumstances of the surgeon. But you need to be able to understand the reasons for what they're telling you, and then hear it from several other people and address those same data points that they're focused on, and see what their perspective is. You've heard some stuff this morning that, quite frankly, I'm sure Dr. Zimmerman and I disagree with from some of our colleagues that gave presentations this morning. That doesn't mean that they're right and we're wrong, or that I'm right and Dr. Zimmerman's wrong. For example, I'm very sad to see people thinking that MRI has progressed to the point where we can decide whether or not vascular compression is present only based on an MRI. I couldn't disagree with that more. I think Dr. Janetta would roll over in his grave if he heard anybody say that. But the truth of the matter is that well-intentioned, well-trained, smart people can honestly disagree. And you've got to also keep in mind a couple of other things. Number one, doctors go into either surgery or non-surgery sometimes for, and one of the reasons is that people who don't go into surgery aren't necessarily interested in surgery, or they feel almost a paternalistic feeling towards their patients. And there's sometimes creeps into this relationship a natural tendency that has to be constantly resisted, to say that, or to think that they're somehow there to protect their patients from the surgeon. Because surgery can be risky. Surgery can, lead to complications. Surgery is invasive. Surgery has anesthesia. Surgery involves cutting tissue. But the truth of the matter is, if the cure, as opposed to just the management of a condition, is surgery, then the surgeon is exactly who's needed. And you ideally want to get involved in a group of doctors, both surgeons and non-surgeons, who are working together collaboratively. So you don't have that sort of competitive or adversarial sort of approach. You have them supporting one another and understanding what each other's roles are in the overall treatment of a patient. And I think that's very important.
Absolutely. How about you, Dr. Zimmerman? What are your thoughts?
So, I mean, there's so much agreement between Dr. Linsky and myself, even though at times we do disagree. But the thing, and I know there are patients that we've shared that we have two different opinions of at the time. And sometimes it's the way the patient presents their syndrome or their pain or their satisfaction with current management that will make the recommendations of the surgeon vary. And as Dr. Linsky said, when there are two, and even if there are 2, 3, or 4 different experts, even on the MAB, there are times when we have a little bit different perspectives of what's the best thing or the right thing to do. I think clearly one of the things is that Dr. Linsky mentioned that I had started to talk about earlier, the issue and the distinction between management of your medical condition and a cure from disease are very divergent points. And if you could be cured of cancer, you probably prefer that as opposed to managing your cancer with chemotherapy on an ongoing basis. I'd rather be one and done and have my cancer gone than have to always be vigilant about taking my medication. Otherwise, it's going to come back. I view trigeminal neuralgia the same way. And from a standpoint of when people interview me and ask, why do you find the care of these patients so rewarding? I say, because it's really a very different perspective. It's a life-changing event. When you take a condition or disease that the patient's been told this is chronic, you'll have this the rest of your life, and it's a chronic condition, a chronic medical condition, which is a class of medical conditions in and of itself. And you get to change their understanding, the perspective, and the reality for them that, no, this is not a chronic condition. This is a condition that can be cured, and you will be free of disease, or potentially free of disease, because nothing is 100%. But you offer them a cure of a condition. That is a dramatic change. So there's someone that says you're not a candidate for surgery. There may be some good reasons for that. But if you haven't had a real appropriate surgical evaluation, you haven't been given the opportunity for a cure. You haven't been understand that perspective of management versus cure. There's a gap in what's been provided to you as the patient as information. And you should really understand that real situational experience of, I make a decision now to manage my problem, or I make a decision to potentially get rid of my problem. And I think that really needs to be better understood, because there's so much discussion about trying to manage TN. And certainly it's not, no one's going to say that surgery is 100% cure. No one. None of the surgeons will say that. But the real understanding needs to be that there is an option for cure. There is an option of a pain-free life without depending on medication, without being in a fog. And I just hope that more people understand that. And, you know, surgery and rhizotomies are an avenue that gets there as well, although I'm not sure that many of us would say that's the best option to get rid of the condition. Because we like to get rid of the condition without losing any function at all, without damaging any neural tissue. As neurosurgeons, we spend our lives preserving everything possible. But certain options are better for some patients than others. That's fine. But again, the distinction between freedom from disease and managing your disease are very divergent points in a patient's decision-making. And those that support them have to understand that. So I think, you know, in almost discussion, when you see differences of opinions, it's okay, you'll get them, but try and understand the perspective of, is there an option for cure, or am I being led down the path of you're going to be left with this and manages?
I would be aware of 3 specific reasons a doctor says you're not a candidate. Beware of somebody who says you're not a candidate because your MR ruled out vascular compression as a cause of your syndrome. I think that's false, and I think that has been a huge disservice to a ton of our patients. Number 2, you have to be very careful about saying you're not a candidate for an MVD because you're too old. The truth of the matter is, it's not the years, it's the miles, as Indiana Jones said in the Raiders of the Lost Ark. There are patients that when I was in the University of Arkansas, who were age 40 or 50, who I would never operate on. But in California, there are 80-year-old patients who play tennis every day, aren't on a prescription med, and are healthy as a horse, who I wouldn't hesitate. The issue is cardiovascular risk factors, not age. And finally, you have to make sure that you understand the difference in expectations and outcome between typical neuralgic pain, which is sudden, sharp, stabbing, brief, lancinating electric shock-like pain with no pain between episodes, and atypical neuralgic pain, pain that is dull, aching, throbbing, burning, pressure, whether it's episodic or constant. To say that the atypical component of your pain is not something that can be helped is wrong. The expectation, however, has to be very different. The measurement for success for typical neuralgic pain after a surgical intervention is black and white, pain-free. It's like being pregnant. There's no such thing as a little bit. But when it comes to atypical neuralgic pain, the endpoint that is realistic and is honest is not pain-free. It is the endpoint we use for clinical drug trials for trigeminal neuralgia, namely a 50% improvement in the frequency and the severity of your pain. And while for an MVD, let's say, in proper hands, the chances of achieving the endpoint for typical neuralgic pain is 80% in proper hands, for atypical neuralgic pain, at best, that's about a 50% chance. So a 50% chance of a 50% improvement in the frequency and severity of the pain, meaning taking it from a 10 out of 10 before the procedure to a 5 out of 10 or less. To say that that is not a valuable or worthwhile endpoint for a patient and that they are therefore not a candidate for surgical intervention shows a severe misunderstanding of what patients will necessarily themselves call a success. I've had many patients with atypical neuralgic pain or hybrid syndrome say that if you can get it down to 50% and I can reduce these medications doses that I'm taking, that may not be a home run, but that's a triple. Thank you. I don't mind.
Yeah, I think it's so important. First, 2 things that were said here. One is that very good, very compassionate doctors can have differing opinions on how this should be done. And it's one of the reasons it's so important to talk to more than one. And also that you should go in and be asking these questions of your doctors and specifically wanting to know, why is this the best decision as opposed to that? Like, ask those questions to help yourself know that you are comfortable with what the answers are that you're given. I'm going to end with one last question. We only have a couple of minutes here. My last question is, okay, I've gotten to the point that I know I want to have this surgery, and I have decided on that. How do I decide the surgeon I should go to? And I know that I should decide each of you because you're the best, but when I'm walking in to see a surgeon, how do I evaluate that and decide, yes, this is a person that should be doing my surgery for me, or no, this is definitely someone I should not be going to?
Well,
go ahead, Lindsay.
There's a chapter in this book on that, as well as an article in the spring 2015 quarterly on that, where we sort of lay out what those features are, at least for MBD. So in my opinion, that surgeon has to have been trained by a master in the technique, to have learned all the tricks, to have learned all the ways to get out of trouble, and all the variations that you can find in there at surgery. They need to be over their learning curve and not learning on you. And in my case, that's about 50 cases under your belt after you're done training. They need to be doing a minimum volume per year to keep their success rate up and their complication rate low, and using crude Medicare inpatient data samples, only looking at discharge to other than home or death, which means severe disability or death. The minimum number is somewhere between 6 and 12 cases per year, and there aren't many neurosurgeons that are board certified in the U.S. who are doing 6 to 12 MBDs per year. This is a rare condition. Finally, in my opinion, or second last, in my opinion, they should only be doing this operation with intraoperative AVR monitoring, which lowers your hearing risk by 50%. They should be ideally surrounded, as Dr. Zimmerman and I have already talked about, with all the other pieces in the puzzle necessary to optimize your outcome. Neuroanesthesia, the personnel in your clinic, a dedicated neuro ICU, the neuro monitoring techs at surgery, the neuro techs handling the Teflon and the equipment, the dedicated neuro nurses, not just general med surgical nurses in the neuro ICU to have your result. And this is somewhat of an academic bias, so take it with a grain of salt. But I really do think that your best results are going to be with a surgeon who doesn't stop following you after your 90-day global, that are following you long-term, assessing their outcomes long-term so that they know whether what they're telling you is reality checked against what their real results are going forward. And those are the key features that I would think. And I'd be very interested in what Dr. Zimmerman thought.
Absolutely. Dr. Zimmerman?
So many of the same things. I think when the patient calls, how do you discern that this is an experienced and very advanced surgeon with regard to TN management and TN surgery? A lot of word of mouth is, word of mouth from other patients. And I think the support groups are very helpful. FPA, TNA, the Facebook support group and other groups out there are good because you get a preponderance of people that have had a good experience. And I think that's a fairly unbiased. Obviously, that patients that don't have a good outcome sometimes tend to be more vocal and loud, and the patients that are very successful with their outcomes tend to say, I've gotten rid of my disease, I disappear from that world. But the other thing is the questions you ask as a patient, see what the team says. So if you want to talk to the allied health staff, because frequently when you call, you won't get the surgeon at the other end of your line. You'll get an office staff person, you'll get an advanced practitioner, NP or PA. And you can ask them about the practice. So they say, oh, we haven't done one of those, or we don't have anything special for those patients. So there's not really a protocol. If you ask about a protocol, what's the system you have for TN patients? How do you manage them? Do you have a special MRI available? A lot of that question asking that you mentioned up front when you come with your notebook is the way that you decide this is a systematic approach to trigeminal neuralgia in this institution. Because while the surgical skill is one measure, an indirect measure of that surgeon's skill is the reflection that you get from the rest of the institution, the nurses, the staff that are there. When you see that system is in place, you know that surgeon likely has a busy practice in trigeminal neuralgia and has organized their practice to focus on the care of these patients because they are a concentration in this individual's world. They don't do, well, I do brain tumors, and I do trigeminal neuralgia, and I do endoscopic surgery, and I do microscopic surgery, and I do minimally invasive surgery, and I can do a few fusions in the spine when I have time. That's, a busy surgeon is not always the best person to go to. A surgeon who's busy and specializes in the area of your condition is a better advantage. And I think the questions you talk about that you bring in your notebook and the assessment you get, because many times you'll go to the office and call them on the phone, or the first interaction you'll have in the office is with someone else on the team besides the surgeon. Or after that, planning for surgery, scheduling of surgery. If they answer all your questions with clarity and with consistency, in other words, you ask the question, you may ask it again, you get the same answer. That's very important. When you get inconsistency, it's very frustrating and can be very disconcerting to say, they said there's nothing special, and then someone else said, oh, we do this all the time. Well, the last person I talked to said we don't do them at all. Or we've done one like last year. So you really have to listen and think critically about the answers and information you're getting.
Wonderful. I want to thank both of you. You have just been wonderful speakers and given us great information. It's good to see both of you. And now I am going to turn it over to the CEO of the Facial Pain Association, Allison Feldman.
All right, thanks, Mark. Thank you very much, Megan.
Hi, I'm Allison Feldman, and I have the honor of serving as the CEO of the Facial Pain Association. Thank you so much, Megan. That was such a wonderful segment. We're so glad you can join us today. 2020 has been a really challenging year. I think that is something that we can all agree on. And it's even more challenging, I believe, for people who are affected with facial pain because of the increased isolation. So at FPA, we have really pushed ourselves to ensure that we can continue to produce and provide programs and information for you, because slowing down and stopping and not being able to offer those to you, we're just simply not an option. Next slide, please. So our first virtual conference, we're so excited to be here, and we are thrilled to be able to let you know that we've had over 600 people registered, along with your family and partners and loved ones who are watching with you. And there are people here from from 47 states and 14 countries, including Australia, Switzerland, Turkey, New Zealand, Vietnam, and others. And what does this say to us? There are many people out there who need answers. And what does this say to you? You are not alone, and we welcome you. And we are so happy you could join the Facial Pain Association community. Next slide, please. If you are new to the FPA, or if you haven't taken a look around lately, I just want to quickly go through a few of the programs and services that we have to offer. We have a brand new book, as you can see, and as has been mentioned several times, and it's wonderful. We really encourage you to go to our website. You can download the e-book version, or you can purchase the soft cover. We have support groups, many of which are being offered virtually around the country, and also national groups. Allie and Ann, your two moderators today, both host a virtual support group. We also have local support groups, which will be hopefully in the near future beginning to be able to meet again in person. And we have wonderful volunteers. Shout out to our fantastic support group leaders, as well as our peer mentors. These are people who you can contact. These are vetted, trained volunteers with a variety of experiences with facial pain, treatments, symptoms, life situations, whom you can reach out to and speak with, and they can share their personal experiences. We have our quarterly journal that comes out quarterly, and that contains the most up-to-date in medical information about facial pain and all kinds of relevant articles and spotlights. Our Young Patients Committee is comprised of a wonderful group of people who were diagnosed, who are affected by facial pain, who are under age 40. And later on in this presentation, we will have Kenzie Winslow, and I implore you to stay on. This is at the end of the program, but she has an amazing presentation. You will not want to miss it. We also have ongoing webinars and Facebook Live events. We have a very active presence on social media. We are constantly working to update our website, and we send out emails every other week. They're called our bulletins, and those provide also more links and updates and information. And in addition, we have TN Awareness Day, which is held every October. Next slide, please. We would love for you to get involved. If you are interested in becoming a volunteer, a support group leader, a peer mentor, if you want to share your experience and your stories with others through an article or a video, if you have special skills, if you are interested in spreading the word, please let us know. We would love to have you join us. Obviously, we would love for you also to support the Facial Pain Association. We are a 501c3 nonprofit, and we depend very heavily on your support. So anything you can do to help us with that, we're very much appreciative. We are also, as David Myers mentioned at the beginning of the program, going to send out a survey to you tomorrow morning. It's brief. I think it might be 7 or 8 questions. Please give us your feedback about this event, and you will be entered to win one of 5 copies of our amazing new book. We're also going to be sending out a community survey in January that's going to be a lot more comprehensive and going to ask you lots of questions about all we do. And again, we really do want to hear from you. So please feel free. Our contact information is here on the screen. Again, my name is Allison. You can give us a call. You can email us, and we would love to hear from you. Thank you so much. And now I'm going to turn it back over to Allie.
Thank you, Allison. Our next segment will cover pain management. I would like to introduce Dr. Allie Mackey, Associate Professor of Neurology at the Loma Linda University School of Medicine and founder of the Oral and Facial Pain Center, who will be followed by a pre-recorded presentation by Dr. Politzis. So if you have questions during this session, please type them in on the box and we'll get to as many as we can at the end. I'll turn it over to you, Dr. Mackey.
Thank you for the introduction, Allie. And thank you, FPA, for giving me this opportunity to be here. I'm going to touch upon some issues such as barriers and challenges that patients face when it comes to pain management. I'll be briefly talking about how people reach pain management, problems that they face with misdiagnosis sometimes, practical solutions, and whether everyone should have surgery. Next slide, please. Some of the information that I'll be presenting today may overlap with what earlier speakers have talked to you today about. And we hope that this will not be a disadvantage and will give you a re-emphasis. In terms of how people reach pain management, I have to say, very frankly, it's unfortunately not the beginning of the journey for most people. And in a setting like mine, where I do mostly medical management, I end up seeing patients who have been to several different providers. This may be a visit to the dentist. Some people will have oral pains, tooth-specific pains. They may see an ENT, they may see neurology. They may even start with their primary care providers. One of the most common situations that I face is that patients will be confused, first of all, in how these symptoms present to them, such as a dental pain that has no other origin or known reason to be hurting. And for that reason, unfortunately, sometimes they end up having treatments prematurely. And that can lead to loss of tooth structure, extractions, and those types of incidents. Another problem that we have is there is no common language or frames of reference, both by patients and by providers. There has been some confusion over the years in the terminology that we use with the subtypes of trigeminal neuralgia. So this brings me to discuss and tell you that trigeminal neuralgia is a broad term that we use. There are different subtypes, and this was probably discussed earlier, but there's been a consensus, and sometime in mid-2019, the European Academy of Neurology presented some guidelines on the diagnosis and management of trigeminal neuralgia. The International Association for Study of Pain has actually come up with a simpler classification, and both the World Health Organization ICD codes have been based on this, as well as the ICH, the International Classification, the International Classification of Headache Disorders has also adopted this. We technically now refer to idiopathic, classical, and secondary forms of trigeminal neuralgia, with a couple of subtypes, which include trigeminal with paroxysmal pain only, meaning that pain that will actually just be present for a second in volleys throughout the day, and pain that includes paroxysmal pains and continuous or just continuous background pain. And we do see this in, again, various subtypes. The trouble is with some of these conditions, we need to make sure that we have a proper diagnosis and differential diagnosis, meaning to make sure that we're not confusing it with some other form of head pain. And often we run into patients who may have trigeminal autonomic cephalalgias, or these are trigeminal autonomic headaches, not to be confused with trigeminal neuralgia, that also are unilateral, one-sided, and need to be, again, ruled out before any treatment is rendered, especially if it's going to be more invasive. In terms of the incidence, there's about maybe an 80% incidence of the classic form and about 10% secondary. And now of the classic form, approximately 90% are based on neurocompression. I said, earlier, does everybody need to have surgery? And we'll gradually kind of come up with the answer, and that would be as appropriate based on the situation. In terms of presentation, there are sometimes, very rarely, bilateral presentations. And that should actually alarm our colleagues in that not to dismiss it because it's bilateral. It can happen. It's been seen with patients with MS. And if MS is ruled out, it might be in the beginning stages. We should still keep that on our differential diagnosis. In terms of how patients can help the situation, is to keep a very close diary. Use terminology very descriptively. If you have like an electrical pain, it needs to be described as that. If it's sharp, if it's momentary. The trouble we run into is if somebody presents and they have primary stabbing headache, which is also a very short-lasting, quick jolt of pain, that could be maybe misconstrued as trigeminal neuralgia because of its short duration. So the burden falls on our colleagues also to make sure that we can have a reasonable differential diagnosis. Practical solutions I mentioned is, first of all, for both patient and provider, is to familiarize ourselves with the latest current terminology, the classifications, and before we move forward with anything, we should probably have everything lined up and figured out to the best of our knowledge. One important diagnostic criteria that the latest guidelines tell us is that we must do MRIs. And the MRIs rule out lesions, but they do not rule out vessel compression. If you don't do an MRI, you will never know. And it has to be the right type of MRI. The recommended situation right now is that we would like 3 high-resolution sequences, and with and without contrast, which would also help with viewing other lesions that would not otherwise be apparent. So the usual protocols that we use are the Fiesta protocol, the the CISS, and the DRIVE protocol. And it's important because this gives us a different, I would say, a vantage point to look for compression where we would not otherwise see on a regular plain MRI or even MRI with and without contrast without these sequences. Why is this important? Well, the importance is if we don't establish vascular compression, are we safe enough to go in and have a craniotomy done? And some of our colleagues will be more careful about it. Sometimes we've had situations where craniotomies are done, microvascular decompression, and the problem was not solved, and sometimes added new symptoms and problems present. So it's important to establish this, and without having a consultation with a neurosurgeon and discussing all the details, it would be probably not advisable to jump to microvascular decompression. Other criteria for MVD would be to make sure that the patient's age, of course, health status, and other factors are thought of before making a final decision. In terms of treatment, now, the first line before even going to surgery, we would like to establish the diagnosis by using medications and making sure that the appropriate medication can block the pain and it could be reproduced before we even decide on surgery. Now, if we have, as I said, a compressive situation, surgery is appropriate, should be done. And if not, then I would hesitate. We used to in the past say that everybody should go in and have it early, but we weren't qualifying the other possibilities where somebody might have an idiopathic situation, meaning that there's no known cause for it, and sometimes secondary situations that were not picked up, such as multiple sclerosis. The most common medications we use are carbamazepine, that's been the first line, and oxcarbazepine, which is an analog, similar molecule, and it has been responding very well in most people. Trouble is that these medications can have side effects. They need to be monitored, and they can have interactions with multiple medications that the patients may take, including blood thinners, some of the blood pressure medications, and others. So that has to be considered. Gabapentin has been used in many situations. I typically prefer that for the subtype where the pain is more continuous, and sometimes I add that on as an adjunctive medication to help in a situation where there's both the paroxysmal pain and the background. Other medications you may have heard of are lamotrigine, baclofen, Keppra, and there is another relative of carbamazepine, oxcarbazepine, called eslicarbazepine, which is Aptium. Unfortunately, that one is not FDA approved, as most of these other meds aren't either, but because it's a brand medication, it's much harder to get approved. And in open label studies, the safety and efficacy has been established in a retrospective study, but we still have a hard time getting that one approved for our patients. In terms of acute exacerbations, this is a big problem when patients have breakthroughs and incidents where pain is out of control. The visit to the emergency department is oftentimes a journey in itself because, first of all, the challenge of diagnosis, and then figuring out what is the appropriate thing to do. And most times, unless somebody is admitted, the IV protocols are not used. It has shown that 2 medications. One, the fosphenytoin, which is an IV form of phenytoin, can be helpful in dampening the pain, as well as IV Keppra. But those circumstances actually usually warrant an admission. In terms of other less common treatments, at this time, we also use Botox, botulinum toxin A, which tends to actually block C fiber terminals and the release of substance P. That has been well established in migraine, and we also see that it can help in patients with trigeminal neuralgia. As with any treatment, I'd like to definitely emphasize that not everything is going to work in everyone. There are a variety of factors. One, type of trigeminal neuralgia that may not lend itself to a specific treatment can be a problem. Also, the fact that there are genetic variances in people. No two people will have the same response to the same medication. So we need to factor that in, because one thing doesn't work, it doesn't mean the condition doesn't exist, it just means that it didn't work for that particular patient. The other avenues that are being explored right now, the molecule CGRP, calcitonin gene-related peptide, is being evaluated because of its abundance in patients who have migraine and trigeminal neuralgia. And there are, again, other less known treatments such as class 4 lasers that, again, will be dependent on who will have what type of condition, and then that has to be explored with your pain management doctor. You heard me talk about migraine, or mention migraine a few times. There are common pathways, and in patients who have migraine, it is highly important to make sure that the migraine is addressed, because that sensitization will also exacerbate trigeminal neuralgia that coexists in the patient. At this point, my time is limited. I just want to make sure that we have time for Dr. Plitz's presentation, and I'd like to turn it over to Dr. Plitz's.
Thank you, Dr. Mackey. We're actually going to ask you a few questions before I turn it over to Dr. Plitz's. So you are a pain management doctor. Do you have any recommendations for patients tracking their pain? Because obviously when they come see you, they want the better information they're able to share with you. Do you have any recommendations on apps or what you want to tell you?
Yes, there are some apps. I don't know of any specific ones for trigeminal neuralgia, but there are migraine apps. There are quite a few. One of them is called Migraine Buddy. You can customize that to track the number of incidents and pain attacks, and that can track things for you. You can also keep a log on paper, and I don't expect my patients to come in with a spreadsheet. So as long as you can log the number of incidents and how long these incidents last, location of the pain, quality of the pain, these are the things that I look for. And it helps with the diagnosis and management to fine-tune and find out exactly what subtype.
Okay, so keeping track of, was it sharp, was it stabbing, was it burning, those types of things are helpful.
Exactly, and some of our patients have the subtype where the pain is continuous, and then they have exacerbations that are superimposed on that.
Okay.
And let me just add one quick thing to that, and keep track of incidents where you may have nausea, sensitivity to light, because sometimes that kind of gives us a clue whether the migraine is actually triggering something.
Okay. And just one more question before we turn it over to Dr. Plitzis. Working with a neurosurgeon and pain management, what is important? So maybe you're in the process of getting a referral for surgery, or what is your thought process in working with surgeons?
It's actually a two-way street. In my practice scenario. I get referrals from neurosurgeons who may be doubting the situation, or they would like to take the next step to, make sure that we're dealing with trigeminal neuralgia. So oftentimes those referrals from neurosurgery come because they want to establish, at least have the patient be tried on medication. And sometimes they've already had microvascular decompression, but there's some residual pains, and they need to co-treat and help management. In my situation, once I reach a point where I feel consultation is necessary because of vascular compression, a lesion, that's when I send over to neurosurgery. But we work very closely. It's a two-way cooperation, and it's important to have both in place. You don't just go straight to a neurosurgeon and have treatment.
Yeah. All right. Thank you so much for your insight, Dr. Mackey. That was wonderful. Now we are going to turn it over. Thank you. Now we are going to turn it over to Dr. Politsis.
Thank you so much to the Facial Pain Association and its organizers for the opportunity to be here today. Today I wanted to focus a little bit on getting control of your pain. I'm a functional neurosurgeon, which means my specialty involves improving people's quality of life. That means I see a lot of people that have a lot of different chronic pain complaints, including facial pain. And I wanted to share with you some of the strategies today that my patients and I work on to help empower them with living with a chronic disease. Next slide, please. These are my disclosures. None particularly relate to this topic other than that I sometimes use devices and stimulation to treat pain. That's an off-label use of these devices. Next slide, please. I think when we think about pain, one of the things that happens is that we talk about pain as a sensory event. You think about touching a stove and you think about what that feels like, and we become focused on that sensory event. And, oftentimes we spend a lot of time in the clinic talking with people about where it hurts and how badly it hurts and what makes it hurt worse. And we get a reasonably good handle on narrowing down a lot of those sensory complaints. That's why your doctor is always asking you if it's burning or shocking or stabbing, because we're trying to figure out exactly what's going on. In the case of facial pain, these are very important questions because it helps us to differentiate the type of facial pain you have and thus the appropriate treatments. And that sensation, it can be affected by a multitude of things. So, again, touching the stove example, you touch the stove, and where do you feel pain? Well, you have sensory receptors at your fingertips, and then you have a series of nerve fibers that go all the way from the tip of your finger, up your arm, to your spinal cord, to your brain stem, to your sensory cortex at the top of your brain, and then back down again. So you have that pathway that goes up and that pathway that goes down. And when you feel chronic pain, you can have an issue at any of those points in between. It's a little easier to describe from the fingertip than it is from the face because, though the face in actuality has a similar pathway going from, the face through the nerves to the brainstem, up as described and back. So in chronic pain, you can have an issue with any of those aspects of the sensory pathway. What's less talked about is there's actually two other pathways involved. The psychosocial pathway actually includes both of those. So that's the way you think about pain, so your cognition, and the way you deal with pain, thus your emotional response. And in fact, in parallel to those pathways in the brainstem and the brain are pathways that kind of modulate how you feel about pain and how you think about this. So it's not just the sensation you're feeling, but also the regulation of those pathways as well. And, you know, that's why often with living with chronic pain, a lot of things can come up. There's depression, there's fear of the pain, fear of it striking you when you least expect it, fear about going through a normal life. There's anxiety that's related to that fear. There's a tension. You know, you think you might get a little bit of an inkling of something going on and you're worried that's going to cause an exacerbation. So we tend to focus on those things that we know coincide with the pain. On top of that, you know, there's different people that you interact with have different thoughts about pain, you know, whether that's going to your primary doctor, whether that's explaining to your family and friends what you're going through. There's many different aspects of this. And, you know, how does that affect you? And how does that affect your relationship with people? How does it affect their perceptions of you? How does it affect what role you're able to play with your family or at work, and just in your life in general? Next slide. So there's a difference between acute and chronic pain. And I think this is really important to understand in terms of that tri-dimensional response to pain that we just talked about on the previous slide. So acute pain exists for a very good reason. It's a reminder. It's a reminder not to touch the stove. It's giving us the danger signal. It's giving us the pull your hand away signal so that we're able to protect ourselves. Chronic pain is a little bit different than that. It starts with that pathway that, you know, is trying to protect us. But then over time, it changes to incorporate those other aspects, that emotional and that cognitive response. And, you know, that's kind of termed the whole pain experience. So yes, you're still feeling the sensation, but every time you feel the sensation, that brings up other things where you're thinking, oh my gosh, this hurts so badly. I can't do this. When will it go away? Will I be able to go to, you know, work today? Will I be able to make dinner tonight? Will I be able to do this? And it really compounds the matter. And not only are you know, does your mind do that, but your body actually does that. Your body has an automatic response with the fear that's associated with this that leads to this pathway being overactivated. So, you know, and as you do more, as you have more pain, as you have this for longer, it tends to get worse. As you have more emotion and, you know, intelligent response about what can be going on with pain and more fear, that leads you to avoid activity, leads you to not use your body as much, leads to disability, leads to depression, and it becomes this vicious circle of activity. Next slide. So what do we do? You know, all of this is going on, and when you think about it, you know, it gets really overwhelming. And, you know, I think it's important whenever you're dealing again with a chronic disease to make sure that you're taking control of it. And how can you do that? And, you know, so one of our mantras, you know, in the clinic is kind of one day at a time. And then what you do is you kind of take it one day at a time until you get that rhythm going, and until days become months and months become years. So you want to try to work on changing your pain experience from being maladaptive, like we described in that previous slide, where it's this vicious circle of activity, to being adaptive. And how can we do this? And a lot of this is you internally trying to take control of this. So part of it is a mindset. And, you know, I know that, you know, I know that you're in pain, and I know that pain prevents you from sleeping, and I know that pain prevents you from having normal activities and doing what you want to do. But part of it has to be, you know, just saying, okay, this is the hand I'm dealt, and I am going to move forward as best I can. And these aren't, you know, this isn't built in a, oh my gosh, you know, I'm in this exacerbation and I'm going to go run 3 miles. This is built in millimeters, right? Just inches of activity, just doing a little bit more. And, you know, just being able to stand, you know, a little bit longer to cook dinner, maybe, you know, being able to chop a vegetable or two before it goes in the crock pot rather than, you know, just throwing everything from the freezer. So it's built in millimeters, and you have to understand that and not get too down on yourself. So it's these little changes that really can add up to be big changes. So, you know, what's an example of kind of a thought that's a maladaptive thought? I'm always going to be in pain. I'm unlikely to keep going to the doctor because they tell me the same thing. You know, when you go to the doctor's office, you say, I've been dealing with this for 10 years and, you know, it's a new doctor. And rather than thinking, hey, this is a new doctor and maybe they have a trick up his or her sleeve that, you know, is going to help. And, you know, by trick, I mean a new therapy or a new way to think about this. And so you have to change that. And again, this isn't something that happens overnight. This isn't something that starts in your deepest, darkest moments. This is just when you wake up out of bed that day, you know, just saying, today is going to be a better day. I am going to take control of this. This isn't going to let me down. I believe that my symptoms can get better. If I can cope, things are going to go better. So I'm going to work on this while my doctors work on managing the sensory aspect of this. So other than thinking about it, what are some other things you can do? Well, exercise is a great thing. And, you know, exercise does a variety of things. It gets the muscles moving. It gets your body active. It puts you in a different, you know, frame of mind. I don't have runner's high, but I wish I did. But, you know, so many people will talk to you about that. It's just about the adrenaline that gets you going in order to kind of change, you know, your body's biochemistry so that you may be in a better spot at that time. For me, you know, I don't run, but I do a lot of yoga. And what does that do? You know, not only am I exercising, but I'm relaxing the muscles. You know, I'm tightening them and relaxing them and gaining control over what they do. And with that attention, with physical exercise, it's a good way to practice maintaining control. Doing all that helps to relax the brain ultimately. This enables you to maintain hope. Next slide. What about when you go to the doctor? You know, you can do, you know, all these things on your own. And, you know, by the way, I'm a big advocate for mindfulness and other type things. But what about when you go to the doctor, and how do you keep that positive energy when you go to them? A lot of doctors don't know what to do with chronic pain, and because they don't know what to do, you know, they don't like doing it because they feel powerless, and you know, it's a hard situation. So you have to make sure you find the right doctors that give you the empathy and support you need while having the clinical knowledge to help you get better. Be prepared. When you go, it can be a very emotional response because you're in such pain and you just want to get better. And, you know, it's really hard to hear anything that isn't, oh, I'm going to make you better. So make sure that you have your questions written down. Take notes if you can. You know, otherwise, I think a really great thing to do is bring a friend or a relative, because it's good to have two sets of ears so you can hear things a little bit, because you're going to hear things a little bit differently because, you know, your own experiences that you bring to there. Make sure that you tell the doctor what's going on. We can't help if we don't have a good idea. So sometimes, you know, there's people that are very stoic. We need to know how this is affecting you in your life. We need to know how you're tackling this, what you've done. Speak freely. Talk about what's working and what's not working, you know, and really think about what's working. We know that you're in pain, otherwise you wouldn't be at the doctor's office. But if you can tell when, like, you even get an inkling of relief, that helps us decide. Be informed. Know what the next thing out there is. It's great that you're all attending this conference and able to be doing this. And, you know, sometimes doctors, you know, aren't hearing what you say. don't be afraid to say no or to push back a little bit and say, I've done that. That didn't work. Why is this different? And ask questions. Making sure that you're in the right partnership is very important. You, as the patient, should always be at the center of the care team. Let me say that again. You, as the patient, should always be the center of the care team. And so make sure you find a relationship where that happens. Again, Rome wasn't built in a day. These are moving forward by inches. Take responsibility, to help your doctor and to help yourself reach those short and long-term goals. Next slide, please. What else can you do outside the doctor's office? Well, I mentioned mindfulness and yoga. Other things, learn to set priorities. Don't put super high expectations on you. Think about all those people that yo-yo diet. And, I've done it myself, where you put yourself in an extreme change or an extreme expectation from where you've been. You're not going to go out and run 5 miles tomorrow if you're not a runner. Learn how to set priorities. Maintain a balance. Don't put too much pressure on yourself, because that gets you back in that maladaptive cycle. Do something nice for yourself once a day. Make sure you have something that brings you joy that you do at least once a day. And then write that down in a journal. Write down something, the good things in your life as well. Continue to learn. Again, don't go nuts on Google. You can find any information that you're looking for. Make sure you use reputable sources like FPA provides. Join support groups, talk to other people, figure out what's worked for them. Sometimes, they'll have strategies that you've never even thought about. Sometimes it's really a great thing to volunteer to help others, or to put something above yourself and your own needs. That allows you to shift your focus away from your pain and onto something else. When you have a good day, celebrate it. Note that this has been really a great day, and make sure you give yourself a pat on the back and say, this is like that one day in the days that I'm stringing together. And don't put too much pressure on it. You're going to have ups and downs. So don't worry if the next day isn't as great as that today is. Tomorrow, or the day after is going to get you back to just where you were today if it's a good day. Share your story. It's really empowering for patients, no matter to hear another patient talk about what positive has happened. It's one thing when it comes from me. It's a whole different story when it comes from somebody else. Help them move forward and believe that there's hope at the end of this journey. Next slide. It was really a great pleasure to be here to speak to you today. Helping people in these situations, not just with what I can provide clinically, but in terms of reframing their pain and empowering themselves is something I'm particularly passionate about. Please feel free to email and contact me at any time with any of your questions. And I look forward to talking more. Thank you.
Now I would like to introduce Dr. Jeffrey Fogel, who is a board member, facial pain patient, and a pediatrician, and bring back Ann Semecki, who will they will have a conversation about the top questions people have regarding the use of medical marijuana. So now, Ann, I'll turn it over to you.
Thank you, Allie. Is Dr. Fogel in the room?
Yes, he is.
Oh, good. We can't see you.
Sorry. Yep.
Hey.
There we are.
Hello. How are you feeling today?
Perfect. How about yourself?
I'm feeling great. I'd love to talk about medical marijuana for facial pain.
Likewise.
So we're going to answer the most commonly asked questions, and I'm going to start with the most basic one, which is, why would I take medical marijuana for facial pain? I'm not like back in my 20s or anything like that, or maybe my teens or in college. What is this with medical marijuana, and does it work? And the truth is, it does. And there hasn't been very much research at all on the use of medical marijuana for facial pain in particular, but there's a lot of evidence that medical marijuana works to relieve neuropathic pain. And while the amount of relief varies from study to study, most studies show that there is low to moderate pain relief using medical marijuana. And more importantly, medical marijuana is very useful to overcome allodynia. And allodynia is that, we've heard this before today, that feeling where a very light touch causes an undue amount of pain. So that would be a very important thing for people with facial pain. The other reason you might want to use medical marijuana is that it's a great substitute for opiate-based pain relievers. And there's research that shows that there's been a 64% reduction in the use of opiate-based pain relievers among people who are using medical marijuana instead. We all know that the misuse of opioids is not only a public health problem, but can be a social and economic problem for people who are using it. And while opioids might have their place in emergencies, they don't work especially well in the long term for neuropathic pain. The one thing to know is that medical marijuana should be considered a complementary medicine, not an alternative one. So you're going to take it along with your other prescription drugs. So in a study done by some pharmacists, it showed that medical marijuana should be used as a fourth level drug behind, I forget words sometimes. Does that happen to you sometimes too?
All the time.
All the time, I know. So behind your anti-seizure meds, behind your antidepressant medication, and even behind some other pain relieving drugs. So,
so Ann, what you're saying is what you're saying then, that the marijuana is basically used for the pain, and the other medications are used to control your disease symptoms before they get to pain?
I think it varies from person to person, but for the most part, yes. I personally use marijuana for flare-ups. So when I have, Dr. Fogel will explain this a little bit more later, but when I'm having a flare, I vape a little bit, and that gives me immediate relief. And I also use it when the pain is interfering with my sleep, or interfering with actually getting to sleep. So those are my uses for medical marijuana. Now, one thing to keep an eye out for, and I went to a conference on medical marijuana a couple of weeks ago, and I saw that there was some research underway to show that, or to see if medical marijuana can take acute pain and prevent it from becoming chronic pain. And wouldn't that be great for all of us who can make that change? So I'm a fan, and I know that Dr. Fogel's a fan. So I don't know. Is it addictive? It's illegal in some places? What's the story on that?
Well, a lot of people erroneously put it in the same category as heroin, and that's because in the FDA scheduling, it is in the same category. But we need to go take a little bit of a history lesson, and I won't bring you through the whole past 80 years. But back in the 1960s, marijuana, they didn't know how to classify it in terms of the FDA's 5 schedules of medications. So they put it in the same category as heroin as a holding place. And the Schedule 1 means something is highly addictive and of no medical value. And it just sat there while they tried to figure out what it was, where it should be rather, and they ended up not doing anything. So it's just sat there since the 1960s. Marijuana does not share any of the addictiveness or abuse potential that heroin does, even though they're in the same schedule. Now, interestingly, OxyContin, which is used quite readily for pain, is a Schedule 2 drug, but it shares the same receptors in the brain as heroin does. So when people can't get oxy, they end up switching over to heroin, which gives them the same effect, and it's cheaper and easier to get. So while marijuana doesn't lead to heroin, OxyContin can. Furthermore, if we actually reclassified all the drugs today, marijuana would probably be a Schedule 3 or 4, something similar to Tylenol with codeine. But the interesting thing is that nicotine, which is addictive and has no medical benefit, would now actually be in Schedule 1, the same as heroin. So the whole system doesn't make a whole lot of sense. If you look at addictiveness versus dependency, dependency is a desire to have it versus a need to have it. While marijuana is not physically addictive, it does, in small percentage of people, it's actually 0.2%, does create a dependency. And that's highest in the 20 to 24-year-old age group. In terms of safety, it is one of the safest medications around. It's even safer than Tylenol. There has never, ever been a fatal overdose of marijuana, and it's been calculated that someone would need 1,500 pounds of marijuana in a 15-minute period to get a lethal overdose. Obviously not something that anybody can do.
Or could even afford, right?
Well, that's true. Yes.
So if I were someone starting out on wanting to use medical marijuana, what kind would I take? What would I ask for when I got to the dispensary?
It's a good question. We get that a lot. And the first thing is we need to take a step back and know that all marijuana is not marijuana. And what I mean by that is I want to bring you over to my high-tech whiteboard over here, and hopefully, can you see this? Because I'm not able to get feedback. Is that coming up?
Yes.
Okay.
It's very nice.
So you have, oh, thank you. You have marijuana, which is composed. What was that?
Did you do that yourself?
Oh, yes. Yeah, about 3 hours ago. Marijuana has over 150 different components to it. The main three are the THC, CBD, and the terpenes and flavonoids, which are just other essential oils. So we're basically today going to just talk about these two. First of all, to get rid of the elephant in the room, CBD is very, very popular. But CBD alone does not work for pain. That's been shown over and over again. There is a placebo effect, so that somewhere around 20% of people will say that the CBD helped them. But in the same way that a sugar pill would also, about 20% of people would say it helps them. So it doesn't have any central effect. It does work for, putting it on your knees or, for pain, arthritis pain. It doesn't work centrally in the nervous system on the trigeminal nerve. And then we have THC, and that is the psychoactive component. And that has two different species, which is the sativa and the indica. Now, I did say this is the psychoactive component, but it's dosage dependent. So the more you take, the more either high or sleepiness that you're going to get. And there are varying ratios in the products of the THC to CBD. Actually, when somebody's starting out on it, it's generally recommended to go with a higher CBD dose and a lower THC, so you don't have as many of the side effects. And then over time, you can increase one or the other as need be. Oftentimes you'll find that the THC has to be increased relative to the CBD to get a good pain relief. So now we do have indicated on here about the sativa and indica, and each one has its own properties. The sativa is the one that gives you more of the energy, the typical, what everybody thinks of as the marijuana high. The indica is more of a relaxing effect. It makes you calmer, more sedative. And then there's the hybrid, which is a combination of both of them. And it also can be in varying ratios. So what some people can do then is use the sativa during the day so they can be productive, and the indica at night to help them sleep. So that's a basic overview. That's why when people just say, I took marijuana and it didn't work, there's too many variables that you have to keep at it, keep trying it. And, you know, I haven't had anybody yet who I've spoken to who didn't keep at it until they got their right one. It just takes time and patience sometimes.
Yeah, from my experience, it was a little bit of trial and error till I got it just right for myself. And it was also a little bit of trial and error on how I should take it. Like, how would you recommend taking medical marijuana? Like, in what forms?
Well, it's not so much how I would recommend. It's, you know, when people ask me that question, I say the best route for them is the one that works for their needs. There's all different delivery methods and efficacy. So I think if we just take a moment to look at the different types, then each person can say, you know, that would work for me because of my medical condition, or I prefer this, or for my daily functioning, this would work better. So if you know the properties, then it becomes easier to make that decision for yourself. So the first thing that everybody's aware of is the inhalation. And inhalation, there's two different kinds. There's smoking and vaping. The benefit of inhalation, it has the fastest effect. It can work within just minutes, and it lasts 3 to 4 hours. Another advantage is that because it does wear off so quickly, if you don't get relief within 30 minutes, you can take another dose. I'll mention later on the difficulty with doing that with products that are longer to get effectiveness. So it is the most efficient way to titrate a dose to figure out what is best for you. It's also the best way to be able to use one strain during the day and one strain at night, because again, they're only lasting 3 to 4 hours. Now, between vaping and smoking, there's also a difference. Vaping is when you heat the oil in a vape pen till it becomes a mist and you inhale that. Smoking is, you know, the 1960s, using a bong and smoking the bud. Now, there's a difference in terms of the efficacy of the two. With vaping, you get 90% of the THC and 10% of the smoke toxins. With smoking it's the exact opposite. You get 11% of the THC recovered and 89% of the smoke toxins. With either method of inhaling, you do not want to use it with any lung conditions such as COPD or asthma. But it's important to note, and they've done this studies with people who smoked, 5 joints a day for 40 years, and they found that it does not cause COPD or lung cancer. So that's the inhalation method. Next thing to talk about is the oral.
Dr. Vogel, can you inhale either of those forms, either the sativa or the? Okay, can you just step a little closer to your board?
Oh,
thank you.
Okay, you want me to put the board back on?
Yeah.
No, you're fine. Just stand a little bit closer to it.
Okay. Yes, what the product is in the delivery method is totally different than the delivery method itself. So, any of these products that I talked about can be used with any of these delivery methods. Okay. Is that clear?
Yes.
Okay. So, going on to the oral method, it is effective, but the absorption isn't as precise. It does have a longer onset of action, so it can take 3 to 4 hours till you feel better, but it lasts longer. It can last 8 to 10 hours. Because it takes 3 or 4 hours or 5 hours, it's more difficult to adjust the dosage to find out what's going to work for you. So it can take weeks to get that, whereas with the inhalation, you can get to your good dose within a couple of days. With the oral, you don't want to use it if you have any GI motility or malabsorption syndromes. The next way to do it is the sublingual, and I have a little, this will be a little show and tell. It's the oil that you put under your tongue, you hold it as long as possible. And this is an example of the tincture that's in a dropper form. You just like an eyedropper, you put it in. This is the tincture that, again, you would just spray under your tongue and you try and hold it there. It does have a fairly rapid onset of action. It's not as fast as the inhalation method, but it's not as slow as the oral method. The other advantage is if you don't want to be inhaling something, that's for those people who don't want to do that, this is a very good option. And it can be used with any lung conditions or GI conditions. So that's an advantage if anybody has those other things going for them. The last thing is the topicals, and that's the creams and lotions. And that works locally. So if you have, facial pain that's, more on the surface feeling, that can work. But it does not, as I mentioned before, get absorbed. So it doesn't work on any central pain that people might have. That's a good, that's a little bit of an overview of the different methods of delivery as well as the different products. What else have you found that you came up with, Ann?
Well, another thing that we get asked all the time is, can I travel with medical marijuana? So if I'm going someplace, can I bring it along with me? And mostly this is asked if people are traveling far and they're going to be away for a while and they want their medication with them, and that's perfectly understandable. So the easy answer is no, but we'll get into the more complicated answer in a minute. Since marijuana is still illegal at the federal level, traveling with it across state lines is technically not permitted. And it's not even permitted to fly from one state where marijuana is legal to another state where marijuana is legal, because that's crossing a state line. So if you're going to the airport and you take the marijuana in your checked baggage, in your carry-on baggage, and you go through the security where the TSA agents are, it's important to remember that they are federal employees and they must abide by current federal laws. So if they should accidentally, they're not looking for it, but if they should discover some medical marijuana, they are obligated to call local authorities, which at least in New Jersey would be the New Jersey State Police. And those officers would decide what to do, and you really don't know. It could be a good day and they'll just say, take it with you. It could be a bad day and they'll confiscate it. And maybe it could be worse.
And the TSA agents are specifically not allowed to make a decision about someone's medical marijuana card. So you can have it, if it gets found and you show them your medical marijuana card, it doesn't matter to them because they are not allowed to make a decision on it. They still will call the local police.
Right,
They're the
and you're
ones
actually,
who will make the decision.
they'll make the decision for you.
Meanwhile, you're probably going to miss your flight.
Yeah, exactly. So it's got some degree of risk. For international travel, the picture's a little clearer. It's really a big no-no. There's a patchwork of legalities across countries outside the US. In some countries it's legal, in some countries it's not. In other countries, it's legal only for citizens of that country, so it can be legal but not for you. And in some other countries, like Asian and Mideastern countries, it's even small amounts will get you locked up. You'll be in prison for even sometimes for several years. We hear in Saudi Arabia the penalty for carrying drugs, drug trafficking, is death. And the other thing to remember if you're outside the U.S. is you might have language barriers. It might be difficult to contact some legal help, and you won't get any help from the U.S. Embassy since that's federal. So in conclusion, it is illegal, and we cannot possibly recommend traveling between states or internationally with medical marijuana. That said, people do travel across states by car, medical marijuana in their car, because it's unlikely to be discovered. And some people even find creative ways to bring it aboard planes. And whether you choose to do that is really up to you. I mean, it depends how risk averse you are. If you think you can try it, you don't mind it being confiscated or maybe getting some kind of penalty, you'll bring it. And if you're not, you won't. I know the first time I traveled without mine, I was miserable because I was really in pain. So I'll have to find some creative way to bring it next time. But
and what about
yeah,
the drug sniffing dogs?
Oh, the dogs. I love dogs. Did you know that? The dogs are actually being trained to be not sensitive to the smell of marijuana. So the dogs that used to be able to sniff the marijuana and sit down in front of the piece of luggage that had it don't do that anymore. They're focusing more on more dangerous drugs. So the dogs don't detect it much anymore.
And I guess we do have some good news with the election. Now 5 more states have legalized marijuana. 4 of them legalized recreational marijuana. 1 of them, I believe it's Mississippi, approved medical marijuana. So now we have, I believe the number is 39 states that have now approved medical or recreational marijuana. But one of the questions that comes up sometimes is, well, if my state has legalized recreational marijuana, why should I bother going through the medical marijuana program? Why should I spend the money for it and have to go see the doctor and all that aggravation? Why not just show up? And the basic answer to that is that in the states that I have checked into and that have just recreational marijuana, they don't really have the focus on getting a product that's in your best interest. A lot of them, you just go in, they say, well, what do you want? And as a facial pain patient, you may not know what you want. You may not know about all those different products, what the benefit of a sativa, indica, hybrid, ratios of CBD to THC. So you're kind of left out in the cold. For example, California, I've checked into it, and people there are not giving it any help at all. In Pennsylvania, they have a very good program where you actually have to meet with a pharmacist at the site before they'll give you any marijuana, medical marijuana, and they go through the bunch of questions that I just was going over in terms of what's in your best interest, how do you want to take it, what are you looking for, how often do you need it, what's your daily schedule like, and all that stuff. So they really can help you. So if I had a state that has both programs, I would still recommend going through the medical marijuana part of the program.
And I would agree with you. This was a great conversation we just had, and I wish we had all day to talk about this because there are so many more things we could say, but time has run out. And
yes, we have a list of what, 20 questions or 30 questions?
Yeah, in 20 minutes. Yeah.
I guess we shouldn't say we weeded them down.
Okay, well, thank you so much. And
You're very welcome. Thank you, Ann.
Well, you're welcome. And now I'd like to introduce Dr. Gary Stanton, who's a neurologist at Emerson Hospital, and he's going to be discussing acupuncture. So tell me, Dr. Stanton, if I have facial pain, why would I want you to put needles in my face?
Because it might help.
Oh,
it might
take
help.
it away. Okay.
Thank you very much. So next slide, please. I don't see my slide here.
All right. Hello, doctor. Do you happen to see it in the top left corner?
In the top left corner, no. I don't see it at all.
Okay. 1 second. All right. What is currently on your screen?
Well, I see the, looks like a prior talk, trigeminal neuralgia, introduction, recognition, diagnosis, treatment. In the upper left-hand corner, I see you, the moderator, and in the upper right, I see myself. But I don't see my slides.
When you hover over the bottom of the screen, do you happen to see an HD button? And is that selected?
The bottom of the screen. Yes, I see that. I click that.
Yep, please click that.
All right. Thank you very much.
No problem.
So I will be talking today about acupuncture. The acupuncture is an increasingly valued form of therapy for a variety of conditions, mainly because it often is helpful, but also it's relatively safe. More and more insurance companies are now accepting acupuncture. I live and work in the Commonwealth of Massachusetts. In just the past couple of years, our Medicaid insurance, which is called Mass Health, has begun to cover acupuncture. And now for the first time this year in the Commonwealth of Massachusetts, Medicare is covering acupuncture services for treatment of lumbar pains. And so more and more we see in our Medicare insurances and also other private insurances coverage for acupuncture. There are many good schools of acupuncture to train licensed acupuncturists, and more medical schools are training physicians, as was my case. So I think that in the future, I hope to see more acupuncture applied for trigeminal neuralgia in addition to other conditions. Today, I'll be talking about acupuncture with two considerations. First, I'll talk about acupuncture from the point of view of its history, what we would call traditional acupuncture. And then I will go on to the idea of what are called microsystems. So traditional acupuncture, of course, acupuncture is very old. It's at least 2,500 years old, some say more, and it's most famous for its development in ancient China, although in other parts of the world, acupuncture points were recognized, but never reached the apogee of development as we've seen in China. I don't speak Chinese, but I'm told that the Chinese words for acupuncture may be translated as treatment by needles and heating. To give you an introduction to the conceptualization of acupuncture, I'll say it's based on an understanding of health and disease, which is reflected in identifiable patterns of harmony and disharmony, which in biomedical terms we can loosely translate as health and disease. An advanced conceptualization of an order of the universe, given the name Tao, which is manifested through energy, which is generally translated by the word qi, and the polarities of qi, yin and yang. Next slide, please. How does a traditional acupuncturist approach acupuncture therapy? Well, there's a consideration of human beings as seen living in an environment between heaven and earth, with heaven and earth each bringing its respective energies and influences. We can all relate to that because we can all understand how a very hot day might affect us one way and a very cold day might affect us another way. So this is an integral part of the consideration of acupuncture. Then patterns of disharmonies in human beings are considered to be manifested in their symptoms, which is how we feel. In this case, today, we're talking about trigeminal neuralgia, facial pain, and also in clinical signs. That's what a therapist or physician might identify on examining a patient. In the case of acupuncture, such as changes in the pulse, changes in the appearance of the face, tongue, and abdomen, and also changes in the reactivity of the skin points, which are called acupuncture points, which are localized on what are called meridians or channels on the body's surfaces, and are in theoretical terms and traditional terms are felt to be conduits of energy. Although we all value the therapist who can treat disease and help us with our symptoms, in ancient China, the greatest emphasis and admiration was given to those who could help prevent disease. Next slide, please. Once a pattern of disharmony is recognized, then harmony or health may be restored by a method of placing most commonly thin, sterile needles in selected skin acupuncture points. Sometimes the points are even massaged or heated. This goes back to the notion of the definition of acupuncture as treatments by needles and heating. Traditionally, the points might be warmed by burning a small plant leaves, which is called moxa. Another message here, though, is that many people who hear the word acupuncture reel back or recoil, thinking, well, the idea of having needles placed into me is an anathema. Well, the message is that it's possible to treat acupuncture points in non-needling methods. In acupuncture theory, treating body surface points will affect the relative balance of yin, that should be yin and yang, and the movement of other constructs, which are called qi, blood, essence, and fluids, and ultimately aims to restore the harmony or health to the body of the underlying solid organs with a capital O and hollow viscera with a capital V. And I wrote here as defined by traditional Chinese medicine, because it's important to understand that the traditional concept of organs and viscera in ancient China and as practiced now by traditional acupuncturists is different from the concepts of organs and viscera as conceived in biomedicine. So it's not quite the same. Next slide, please. So here I gave you an illustration of acupuncture points and meridians that's seen on the left side of the screen. The meridians or energetic channels on which these roughly 361 traditional acupuncture points are located are given names. In this case, you see I put a point on the hand, the back of the hand of this subject. The LI stands for large intestine. It's the large intestine meridian, and the different points are given numbers. So in this case, it's large intestine 4. If you take a look at that meridian, follow that line up the arm, heading up to the shoulder, you'll see that that meridian is thought to also have an energetic connection to the face. So this is one example of an acupuncture point, a traditional acupuncture point, which when stimulated, perhaps by a needle, perhaps even by massage or other types of stimulations, that might benefit somebody who has facial pain. And in fact, that's a point that if a person with trigeminal neuralgia is having a spate of pains, that's a point that one might gently massage. It's right there at the base of the thumb and index finger on the back of the hand in that fleshy area. Gently massaging that might possibly help neuralgic pains in the face. On the right side of the screen, I also indicated some facial points. Typically with traditional acupuncture, local points, in this case being in the face, might be combined with what are called distal points, as in that large intestine 4 point on the left side of the screen. These points were part of a protocol that was published by a Chinese acupuncturist. You can see the reference at the bottom, Dr. Liu Shaoji, in the Handbook of Acupuncture in the Treatment of Nervous System Diseases from 2002. Next slide, please. Acupuncture microsystems is a relatively newer development in acupuncture. Although the ear itself, the skin of the ear itself, was not included to contain traditional acupuncture points. Traditionally, even the ancient Chinese would sometimes treat an ear point for isolated symptomatic purposes. But in more modern times, a conception of the ear as a focal treatment of a focal localization of a variety of acupuncture points has been developed, along with other so-called microsystems. So here on the slide, you see ear acupuncture is mentioned. It was developed in France, but there were others too. There's scalp acupuncture that was developed in China and Japan. There's a well-known Korean hand acupuncture system. But the French system of ear acupuncture is a little special because it was developed in the West as opposed to most of the other systems which came out of Asia. In France, the method that was systematized roughly 70 years ago was named auriculotherapy. And the doctor who created this system was a physician. So in the French approach, it's guided by biomedical treatment principles. Later on, when word of this advance in microsystems with ear acupuncture was published in Asia, Chinese acupuncturists looked into it, agreed with it, but modified it to be given it in traditional terms. So the way a Chinese acupuncturist might treat ear points might be similar, but it also might be somewhat different from the way a French physician or someone trained in this French style might treat the ear. Next slide, please. Ear acupuncture can be defined as a therapeutic method aimed at treating patients by the physical stimulation of reflex sites in the auricle of the ear. The word auricle refers to the visible, fleshy, external part of the ear, including even the earlobe. But in auriculotherapy, the ear canal that leads inside into the eardrum, that's not treated. So all the treatments are on the skin of the ear, but not deep inside the ear. Next slide. Here is the famous doctor, Dr. Paul Nogier, who developed this system. As with traditional acupuncture, auriculotherapy or ear acupuncture is now recognized worldwide. There are international symposia and congresses. This is very, very well known. In the United States, a famous protocol called battlefield acupuncture has been looked at by the Pentagon and is being taught to health therapists, healthcare workers in the military. Paul Nogier in the 1950s observed patients who had a specific ear traditional point that was performed by a non-physician, a woman whose name was Madame Barin, for patients with sciatica. He thought about her treatment and then from it expanded a whole new system, which he named auriculotherapy, that means treatment by the ear. Next slide, please. This is a drawing of made by Dr. Nogier, and this shows something quite striking. You can see that over the ear, Dr. Nogier theorized that there are parts of the ear that might relate to actually parts of the body. This is what in medicine we would call somatotopic organization. The soma refers to the body and topic refers to a map. So a map of corresponding body points to the structure of a part of the body. Well, the principle of somatotopic organization in the nervous system, especially in the brain, but also spinal cord, is very well recognized. And somatotopic organization is a fundamental fact of neurophysiology. What's different or interesting about what Dr. Nogier did is that he theorized that the same type of somatotopic organization, which is found in the brain, for example, is also represented on the ear. His theory is the basis of the clinical approach to auriculotherapy. Next slide, please. So the biomedical theoretical basis of auriculotherapy can be summarized this way, that many nerve cells in the brain, but also the spinal cord, which process pain, have multiple nerve connection inputs and outputs. Nervous system is very complicated, many different connections. The skin of the ear, as it turns out, has a particularly rich innervation, including the trigeminal nerve, with diverse connections to the brain and spinal cord. Where nerves connect, those points are called synapses, and synapses often have a quality of what's called plasticity in neurophysiology, where there might be dynamic influences on the connectivity of one nerve with another that can be modified or modulated by different methods, different inputs. In auriculotherapy, and I think more broadly in acupuncture, it's theorized that the stimulation of ear acupuncture points, as well as other body acupuncture points, may affect the activity of pain processing nerve cells and their connections, thereby modulating them to diminish the pain experience and to promote healing and repair. So in the field particularly of auriculotherapy, but even modern acupuncture, we also have neurophysiological explanations that serves as some contrast to the more traditional explanations for the function and way to conceptualize traditional acupuncture. Next slide, please. So in the book that was published, I hope that you've received it and will read it, Facial Pain, the 21st Century Guide, I was asked to write a brief synopsis on auriculotherapy or acupuncture in the treatment of trigeminal neuralgia. And in that brief chapter, I mentioned a woman who came to me. This is the approach that I used in treating her facial pain. She was 40 years old. She was a nurse, and she had had a 15-year history of right cheek or maxillary paroxysmal pains, sudden pains that were fairly severe, 8 to 9 over 10, that were triggered by touching her cheek on that side, or sucking on a straw, or even on exposure to cold wind. She had tried the usual medications such as carbamazepine. The problem was she couldn't tolerate them. It made her drowsy, and her voice became a little slurred, and she worked answering the telephone, so that just didn't work out. So she wanted something different, non-medical treatment. And so I gave her this particular treatment. The little marks indicate the points treated. And in this particular case, in her case, she told me that she had a 90% relief of pain. She was able to stop all medications. I want to call your attention on this slide to the area of the earlobe. And if you look to the left side of that earlobe area, you'll see a spot right at the back edge of the earlobe that's labeled V2 trigeminal maxillary division point. So remember that the somatotopic organization is that of an inverted human being, actually a fetal proportion. So that point would correspond to a point of the V2 trigeminal division. Just above it, on that back part of the earlobe, would be V3, and just below it would be V1. So here's another thing that one can try if someone has a facial neuralgia, having a lot of pain, one can try gently massaging that back part of the earlobe right in that area. There's a chance that even gentle massage might help to diminish some of the pains and maybe even help to quash a flare-up. There's a chance that it could. Next slide, please. Ear acupuncture commonly is given with needle therapy, as with other forms of acupuncture. Here, you have standard needles that are placed in points of the ear. Next slide. And in France, Dr. Nogier developed a special needle. The needle is contained in the very tip of that little injector. You might see it just there in the narrowing, tapering part of that canister. It's a 2-millimeter needle with a mini barb at the end. And so when it's put into the skin, it doesn't fall out right away. If you look at the image on the right, the ear on the right, up at the very top of the ear, you'll see at its very uppermost point, the helix, one of those little needles have been placed. Those are called ASP needles. A difference there in the French approach is the patient goes home with that needle in place. So instead of being in the point just for 20 to 40 minutes, as in a typical traditional treatment, that needle might stay in for days, even weeks, as long as it's tolerated, bringing a therapeutic stimulation to that point for a far greater period of time. Next slide, please. This is the last slide, and it's just to show you that a lot of research is being done in acupuncture in general, but as well in ear acupuncture. A lot of the research is coming out of Asia, particularly China, Korea, Japan, but also more and more research is coming out of the United States, Europe, and South America, Australia. And so there's a lot of movement in this direction. We think of acupuncture as an evidence-based medicine. It's recognized as such by the World Health Organization and by the National Institutes of Health. But we need more literature, more validation of the different types of treatment protocols that we can bring to help patients with trigeminal neuralgia and other types of problems. This is just to show you that more and more work is being done to review available literature to try to see how well we are approaching and fulfilling the goal of having acupuncture as an evidence-based medicine. That concludes my presentation. Now I'll turn it back over to Allie.
Thank you so much, Dr. Stanton. That was wonderful. Now I'd like to introduce Dr. Lisa Scott Morrow, clinical psychologist specializing in the treatment of pain and trauma, who will discuss mental health and coping. Dr. Scott Morrow, I'm going to turn it over to you now. Thank you.
Great. Thank you. I'm waiting for my slides to pop up.
Okay. Are they not on the screen yet?
No, I don't see them on the screen.
Okay, what do you see on your screen?
Facial Pain Association.
Okay. So, and do you see? So when you hover over the screen, do you happen to see that HD button?
There it is. It wasn't there before. Okay, I'm clicking it now.
Mm-hmm.
Okay, there we go. All right, let's go to the next slide. Okay, what I would like to do is start off with discussion of two disorders that are really common in the chronic pain population. And the reason for starting with these two disorders is that if you have them and they're not getting treated or they're not getting successfully treated, everything else that I'm going to talk about will fail. Not to be too negative about it, but you just can't progress if either of these things are present. So depression. And when we talk about depression in this context, I'm talking about a very specific kind of depression. Sometimes we call it major depression. It's also called clinical depression, or if you really want to get fancy, we'll call it endogenous depression. And what that means is there is a neurochemical dysregulation. So this is a biological thing. This is not something that you feel in a fleeting way in response to some sort of thing that's happened in your life that's a negative thing. It's not a bad mood, but it is a disorder. And so let's look at it more closely. So at least one of the symptoms have to be present: depressed mood, or loss of interest or pleasure. And here's the significance of this. When I use the term mood in this context, I'm talking about the way you as a patient or you as an individual feel about yourself. And it is true that some people have depression and yet deny it. So if I ask them as a clinician, do you feel depressed? They'll tell me no, when it's clear to me that they are. So that's why we have two things here. The other one is loss of interest or pleasure. So the person may say, no, I'm not depressed, but they don't enjoy things anymore. And that suggests that they are in fact depressed. People sometimes don't want to admit that they're depressed because they think of depression as a kind of weakness, but it is not a kind of weakness. It is not something that you choose. It's not something that happens because people are not trying hard enough. It's a disorder, and it needs to be treated. And approximately 54% of people with chronic pain have it. So 5 of these symptoms: depressed mood, meaning again that you feel depressed, or other people notice that you look depressed, you are tearful, your facial expression is downcast, you don't show the same interest in things that you once showed. So that kind of thing is present. A loss of interest or pleasure in the kinds of things that used to occupy you, used to bring you joy, you used to look forward to them, but they don't capture your interest anymore. They don't move you anymore. significant appetite change from baseline. So either increased appetite or loss of appetite compared to the way you normally are. Most people with depression experience a loss of appetite, about 80%. 20% have increased appetite. And again, this is compared to your own baseline. At psychomotor, this means the way we move, the way we experience our body as a function or a result of our frame of mind. So if you're psychomotor, if you experience psychomotor agitation, that means you feel restless, you can't be still, you feel antsy and edgy. If you feel psychomotor retardation, you feel heavy, leaden, slowed down, lacking in energy. So, you know, people with depression have abnormalities in this way. Some people feel agitated. It's what I call hand-wringing depression, and other people feel this deadness. Fatigue or loss of energy nearly every day, all day long. And of course, it's important to make sure that there isn't some medical cause for this, like hypothyroidism or some other cause. But once we get those things ruled out, it points us in this direction. And it's not something you can talk yourself out of. It's as physical as hypothyroidism or some other medical cause, because this is a biological disorder. Diminished ability to think or concentrate, indecisiveness, the apparatus of the brain, you know, the part that thinks and problem solves, it just isn't responsive. It's boggy, it's slowed down, it's not sharp. And then in very bad cases, people feel like ending their lives. And the real tragedy here is that once the depression is treated, this just goes away. And so if it doesn't get treated and the person ends up taking their own life, it's just a horrible, unnecessary tragedy. How do we treat this? Well, oftentimes we need a medication. And the most effective form of treatment is a medication combined with psychotherapy. All right, let's go to the next slide, please. All right, here's the other big one, anxiety disorder, generalized anxiety disorder. And if we're talking about depression, okay, we'll go back to that for a moment. Any of these symptoms that we talk about lasting 2 weeks or longer starts to raise our attention, like, uh-oh, not good. Anxiety, we have a much longer window, 6 months. And the reason for this is because these feelings that we're going to talk about, they are a normal response to stuff going wrong in your life. I mean, you know, or stuff happening in your life that is demanding. And, you know, any normal person would feel that way. So if it lasts longer than 6 months, it's probably not some response to the situation. And here's the thing, you know, we're not living in a normal time with COVID exploding all around us. So I'm guessing there's probably more of this stuff even than there would ordinarily be, because we're all living in a very, very stressful set of circumstances. Some of us are shut off from family members that we really love. We can't see them. We can't be with them. There's a kind of social isolation that people are experiencing. And I think if you've got the biological predisposition to anxiety or depression, I think it's even more likely that you're going to become symptomatic now, and much, much more crucial that you get it treated. So let's look at the symptoms for this stuff. And again, this is a physical, medical disorder, and so there are physical symptoms. Feeling restless, keyed up or on edge, antsy, not able to get comfortable in your body. Feeling easily fatigued because you're running in this sort of fight or flight state all the time, and it wears you out. Difficulty concentrating, again, this affects the way people think. They can't focus. irritability. And this is a kind of irritability that sort of gets out of the bag, you know, even toward people that you don't want to be irritable toward, like your spouse or your children or your grandchildren or your dog. You know, these are beings that you love and you don't want to snap at them, but you can't help it. Muscle tension. And this is important because, you know, it makes your muscles sore. And it can affect the muscles of your face so that you clench your teeth. And then, of course, when all of that musculature gets tight and, you know, kind of inflamed because of the constant tension, it makes facial pain of any kind, including trigeminal neuralgia, more likely to occur. And then here is this one, this sleep disturbance one. And, you know, both depression and anxiety show up in sleep disturbance, which just, of course, is like, it just accelerates the whole problem and makes it worse. Anxiety, sleep disturbance, usually difficulty falling asleep. So people will just, you know, they'll get in bed and they'll lie there and they'll toss and they'll turn and they'll, but they can't fall asleep. That's classic. For depression, interestingly enough, the problem is people fall asleep typically fairly easily within 30 or 40 minutes, but then they wake up and they wake up over and over again. So sleep is very fragmented. Again, it's not normal and it causes even more problems. So if either of these things are sounding familiar to you, you need to reach out. You need to get some treatment because it will make everything else that you do of a psychological nature less effective. You really can't beat these things if they're present. They need treatment. And interestingly, both of these disorders, depression and anxiety disorder, are very commonly treated with the serotonin reuptake inhibitors, antidepressants technically, but they also work very well for anxiety. Xanax and other benzodiazepines to treat anxiety disorder, not good. Not good. Causes more problems in the long run. Okay, let's go to the next slide. All right. So I want you to, before I go into the slide, I want you to know, I know that trigeminal neuralgia is a beast. I know that. I know that it hurts so bad when you're having episodes. I mean, it's one of the kinds of pain that when people have it, they can't disguise that they're having it. You know, the grimace and the changes that go onto your face, even if you didn't want people to know that you were in pain, you can't hide it. It's that bad. I know that. So when I talk about the things that I'm about to talk about, please understand, I know how hard this is. But what it does to you emotionally and psychologically is so potentially damaging. We all start off, you know, when this diagnosis of pain of any kind comes along, trigeminal neuralgia comes along, we get a name for it. Oh, that's it. That's what I've got. Oh, okay, that's it. And then you begin to think about yourself in a different way. I'm not the person I used to be, you know, the person before all of this started. Something I can't control, something I didn't choose, and something I didn't deserve has come into my life and changed me. I feel helpless. And in fact, in some ways you are helpless. Yeah. I mean, it's not imaginary, it's real. And when you're symptomatic, you do depend on people around you. But then something starts to happen. Something very damaging starts to happen. You start to see yourself primarily as a patient, primarily, okay, as a person who has pain. And that other identity that you had as a mother or a father or sister, brother, wife, husband, partner, you know, an employee or an employer, all of those things that you used to be you let go of, and you become synonymous with your pain. And that's not good. Okay, it's understandable, but it's not good. And then the other thing that starts to happen is you begin to evaluate other people in terms of how much they see your pain, because this is such a crucial, central thing that's happened to you. And you begin to, evaluate other people. Do they see my pain? Do they take it seriously? Do they think I'm faking? Do they think I'm making too much out of this? So the worthiness of other people starts to get evaluated in terms of whether they regard your pain as serious or not. And then people who don't seem to see your pain or don't understand your pain or minimize your pain, they become invisible to you. They sort of get booted out. And this process that unfolds so naturally over time reduces you to your diagnosis, and that is trouble. All right, let's go to the next slide, please. So chronic pain of any kind, but I argue that facial pain is the worst, because our faces, our identities are here in our face. And anything that affects us there has a very profound effect. What happens over time is we begin to get this is kind of abstract, but I think you'll follow me. What happens is we get detached from our bodies, because the body has become sort of the saboteur. It's become an enemy. And so we begin to pull off this sense of self, the I, the me, out of the body. And this is, again, a natural process. We begin to experience fear that is compulsive and repetitive and catastrophic. And anybody, I don't have trigeminal neuralgia, thankfully, but I have had many patients who do. And I have seen people having trigeminal neuralgia attacks and facial pain. And believe me, anybody who has that experience is understandably afraid to have another experience like that. So I heard some tapping. Is that anything I should pay attention to? No?
No need.
What?
No worries. Yeah, you can go ahead.
Okay, all right. So what happens when people begin to feel this fear? They become anxiously self-absorbed. And this changes all of their relationships. No villain here. No failure here. This is what pain does to people. This is what pain does to everyone. But it must be challenged, because it will, it will wreck your life. So as fear becomes more and more and more a part of what you're experiencing, there is a loss of emotional range. All the other feelings and emotions you used to have, you don't have anymore. Your emotional experiences become preoccupied by fear of pain and avoidance of pain. And this inevitably causes you to disconnect from people. All right, let's go on to the next slide. So catastrophic thinking, this stuff is bad. And I would challenge you, you're not bad if it's happening to you, but the effect of it is bad for your life. So I encourage you to do a scan as I talk about this, of your feelings and of your experience. And if you spot this happening, let's get on it. Let's fix it, because this stuff will take you down. Catastrophic thinking, the tendency to overestimate the likelihood of negative events occurring, blah, 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 blah. A lot of words, right? But what it means is, once this catastrophic thinking thing has you, it gets you, grabs a hold of you. It means that everything you're doing and feeling and thinking is devoted to avoiding the next horrible thing that's going to happen to you. And it becomes all-consuming. You're scanning the environment. You're scanning yourself. You're looking for the next horrible thing that's going to happen to you. And it becomes irrational. You start to fear things that are unlikely to happen. And I think, trigeminal neuralgia is particularly risky this way because you have these, I know in type 1, you have these episodes that come out of the blue. They just start happening to you. And then maybe they go away. Or maybe you get on a right kind of medicine and the medicine makes it go away, or you have a surgery and it goes away, but then it comes back. And it doesn't, it's not really and truly hooked into anything you're doing. It's almost random, but it makes people afraid because they start to just spend their energy worrying about when the next episode is going to occur. And that means effectively that pain has taken over everything because there are no periods in between pain where you're not thinking about pain. It's become the center of your life. And that is bad stuff. It's hurtful. All right, let's go on to the next slide. So oftentimes, people who get caught up in this catastrophic thinking have undiagnosed depression or anxiety. And this, again, please don't get caught up in this thought process that anxiety and depression only happens to weak people or mentally ill people. Don't do that to yourself. Because the thing is, you're dealing with something huge. You're dealing with something really, really big. And it is not a weakness to respond to that by becoming anxious or depressed. But it still needs to get fixed. People are afraid sometimes to go out and get treatment because they think that it will mean to other people that the real issue is the depression. It's not really the pain. So if I admit that I'm depressed or anxious, then other people might think that my pain is really overblown or I'm making a big deal out of it and it's really a minor thing. Well, that's not true. Some people may think that, but and you can't stop them from thinking it. Sometimes family members think it, and it can be hurtful, but it is not true. It is not true that when you have depression, that the real culprit in your misery is only your depression. Your pain is still a very significant thing. So I think I'd like to go on to the next slide. Let's move on to there we go. So all of the things that I've talked about, all of these things have impact on relationships. And I'd like to spend some time talking about this because I know out there in the audience, since I've done these things when there were real people out there, which I miss, by the way, your partners are out there. It's not just the pain patient, it's the pain patient's significant other or husband or wife that are out there in the audience too. So let's talk about the experience that everyone has. Research shows that people who are in relationships, partnered patients, do better in general. They're less likely to experience depression and they're less likely to report high levels of pain. But, this is not the whole story. So let's go on to the next slide. When relationships are troubled, when they're going through a rough time, when they're weak and distressed, people do not do well. They report more frequent and intense pain, and they show higher levels of disability. So the takeaway message here is the status of your primary relationship will have an impact on how uncomfortable you are. And this is really hard for people to accept. But if we've got two people, both with trigeminal neuralgia, both having attacks, and one person is in a stable, happy relationship that's doing well at that time, and the other person is in a distressed relationship, the person that's in the distressed relationship is going to feel more intense pain. But that does not mean that the pain is all in your head or imaginary. It's just a very complex effect of the neurochemistry in your brain. But it has to do with the impact relationships have on your mood. Okay, let's go forward to the next slide. So here is this other sort of slippery slope that happens to people coping with pain. Now we're looking at it from the partner's perspective. And in the literature, in the research literature, we use the term solicitous partner. And what a solicitous partner is someone who is trying. Okay, nobody can succeed at this. Nobody can. But loving partners will try to meet their partner's every need. So especially when it comes to avoiding episodes of pain. So the solicitous partner is the partner who's trying very, very, very hard to be there for their partner, but it causes trouble, okay? And this is important, so we'll look at it a little bit closer. People who are engaged in catastrophic thinking, who are caught in that net, cannot be extracted from the net by being nurtured. And it's normal, it's natural when you love someone who's caught in that catastrophic obsessive loop, always, always, always expecting the bad thing to happen. It's tempting to try and love them out of that, to try and comfort them out of that, nurture them out of that, but it won't work. Because this catastrophic thing is consuming. So when that happens, when you're with someone who's caught in that catastrophic obsessive net, you need to, if you do anything, okay, the most effective thing that you can do is to get them to go see a counselor, to go see their primary care physician and maybe get on some medicine. But that is the time that you need to reach out for help, because A, you can't make a difference in what they're experiencing that way, and B, it actually makes it worse. Because what happens is both partners, okay, in a marriage, but it could be a child, it could be an adult child that you're close to. It could be a friend that you're close to. But what happens is both people get engaged in that hypervigilance for what is going to cause the next episode of pain. Oh, maybe we shouldn't go to that dinner, honey, because, if we go to the dinner outside, the wind will be blowing and maybe it will cause your facial pain to act up, So both partners start looking for triggers and looking for ways to avoid pain. And the pain just starts to work its way into the relationship and take over. It's like this big, Jabba the Hutt thing sitting in the middle of the relationship. I'm in charge now. Both people are owned by the pain. And this dynamic will kill intimacy. It kills the very reasons that you fell in love with each other in the first place. It damages relationships. So that's why we have to get away from it. We have to have a better, more successful solution than both people sitting in the middle of a mass of fear trying to avoid triggering pain. Okay, let's go to the next slide. The relationship can feel like it's dying, and yet nobody talks about it, because there is nothing more scary in a relationship of importance to people than talking about the fact that it's not going well. You know, people are terrified of that. It's like, if we put it out in the open, oh my God, if we put it out in the open, it must mean that we are going to end. We are going to end. But the thing is, not talking about it increases the probability that it will end, either actually come to an end or become so lifeless that it's as if it's ended. But yet it takes courage. And this very often involves the partner of the pain patient saying to the pain patient, speaking out to some degree, in some way, about the fact that they're feeling pushed out of the relationship by the other person's pain. It's like this big, huge pain monster has taken up all of the space. And the caretaker develops a kind of resentment about that. And they feel guilty about it. So now we've got resentment with guilt stacked on top of it. And it's very hard to feel connected when that emotional experience is going on. And so what happens is people begin to behave out of obligation. And the other person can feel it. You know, the pain patient can feel that their partner is connecting out of obligation. And then that causes them to start to wonder if the relationship's in trouble. And it just goes bad. And the only way out of this is for people to sit down and talk about it, and to talk honestly, very transparently about your fears and your thoughts and your emotions. And believe it or not, this terribly frightening thing that you're about to do, talking openly, can revive the relationship. It can bring new life to it. Okay, let's go on to the next slide, please. All right, some coping tips. Let's go to the next slide. All right. If you have a history of childhood abuse or neglect and you haven't talked this out in therapy, get into therapy somewhere, because believe me, this is not a good combination. A history of trauma and chronic facial pain, bad, not good. So go talk to someone, and you can talk to someone about the childhood experience of trauma, or maybe you were in a relationship that involved domestic abuse, or it could be all kinds of things. You don't even need to mention your pain, and it will help your pain. Because if you just unload this big burden that you've been carrying for all of these years in silence with somebody who actually can understand, man, the thing about having experienced trauma in the past is very often other people can't understand because they haven't had anything like that happen to them. But I promise you, a therapist who deals with this can understand. They will understand. And that will make a difference. It will help. So if that's there, do right away. Monday, get on the phone and find a therapist. All right, let's go to the next slide, please. And you may need an antidepressant. How do I decide when a patient needs an antidepressant? Well, if their sleep is not good, that's a trigger for me. Like, we got to get something going on. We got to get some medicine on board here. So if your sleep is consistently sucking, and we don't have sleep apnea or some other cause, yeah, let's get an antidepressant on board. And again, without ever talking about your pain will get a little bit better. We know this. It's in the research. Your pain will get a little bit better. Now, here's something to keep in mind, though. A lot of the antidepressants can cause you to brush your teeth. They just do. Not perfect, right? No, they're not perfect. But that bruxing, grinding your teeth, can stir up all this, all of this nerve supply, not good for somebody with trigeminal neuralgia or facial pain. So if you get on an antidepressant, I would suggest that you go to your dentist and I know that going to the dentist is not fun, but this is important. Go and get an oral appliance made, which will just help. Just trust me, it will help. And that way you can go on taking the antidepressant, which will be crucial to your happiness. All right, let's go to the next slide. Reach out early. What's the worst thing that could happen? You could reach out and you don't really need it, or you could reach out and you only need a little bit. You know, that's the worst that could happen. So if you think you might need some psychotherapy, reach out. And if it doesn't feel right, or you think it's helped and you're done, say, so long, I'm done. You know, you don't owe the therapist anything. You don't owe the therapist anything. You don't have to take care of them. That's the beauty of it. Okay, let's go to the next slide. And this is also important. When you have this big thing like trigeminal neuralgia in your life, it's tempting to forget that there are other sources of loss and suffering that are also significant. And those things need to get talked about. And it can get very, very confusing. I've seen this with my pain patients for decades. You know, if you're dealing with this chronic pain monster, you start to attribute every negative affect, you know, every sadness, every anger, every fear to pain. And this is never true, okay? It's never true that all of that negative affect, every single piece of it belongs to pain. Some of it belongs to disappointments that you have in your life for other things. And they all need to get talked about too. Okay, so it's important not to let that confusion occur. Remember that when that happens, that's because Jabba the Hutt, remember that Jabba the Hutt guy? That's because the Jabba the Hutt pain is sitting in the middle of your head. Okay, let's go to the next slide. It's better to see a psychotherapist who has experience with chronic pain if that's what you want to work on. Because a chronic pain therapist has had so many pain patients that they have certain knowledge and chops that a standard sort of like general psychotherapist wouldn't have. But let me be clear, a general psychotherapist, if you can't find a chronic pain specialist, a general psychotherapist is better than no psychotherapist. It's just that you may have to teach your general psychotherapist what trigeminal neuralgia is. Okay, let's go to the next slide. We're running out of time. I think I am out of time, actually, but let me just say this. Don't mind read in relationships. Don't do it. You think you know what they're feeling, and you may be right, but sometimes you're going to be wrong. So use your words. Talk about what you feel. Ask questions about what they're feeling. It takes courage, and you get better at it. You're really not great at it when you start, but more practice makes perfect, and you can get this mind reading thing out of the way. And let's go to the next slide. Let's see what's there. Do not allow your partner to routinely do for you what you're capable of doing for yourself. Man, that is such a harsh statement. It's so harsh, but it's true. Hold on to what you can do. Hold on to what you can do. And partners, allow your pain patient partner to hold on to what they can do. Don't take over everything. You know, let them hold on to some of their autonomy. Let them hold on to some of their strengths and some of their skills. Don't let your relationship just become one big merged blob. Okay? And I think that may be the last slide, but let's take a look. Next slide. That's it. Okay, that's what I got. I hope it was helpful. And so I'll turn it back over to Allie and I'll check out. Love you guys. Yeah, take care. All right, bye-bye.
Thank you, Dr. Morrow. All right, next we have Kenzie Winslow, who is a member of the Young Patients Committee. She's going to share her story on advocating for herself. So Kenzie, I'll turn it over to you.
I'm sorry, Kenzie, we can't hear you. Are you?
I had myself muted. Can you guys hear me now?
Yes, we can.
Okay, great. All right. Hi, everyone. My name is Kenzie. For those of you I don't know, I am a member of the Young Patients Committee and have been since I was 16 years old, which now is about 7 years ago. I'm obviously not a medical professional nor a facial pain expert, but I am one of you, and my story begins like many of yours does. When I was 11 years old, I was playing softball, and then suddenly I wasn't. I was on my knees in the indescribable pain that you all know so well. And then just like that, as quickly as it came, it left. I spent the next few weeks in and out of pain and in and out of even more doctors' offices until eventually I was diagnosed with trigeminal, glossopharyngeal, and geniculate neuralgias. I didn't know what those words would come to mean to me, but at 11 years old, all I knew is that I wanted my first cell phone and I couldn't wait to start middle school. Today, I hope to remind you of a childlike hope that I have held on to since I was 11 on the softball field. I graduated from high school in 2016 with honors and a one-way ticket to my dream college in Malibu. I spent my sophomore year studying and living in Lausanne, Switzerland, and while I was there, I traveled to 18 different countries. This past May, I graduated magna cum laude from Pepperdine with a degree in finance. In a little over a month, I'll be moving to Washington, D.C. to start a brand new job in a city that I've only visited twice. I have dreams to take over my grandfather and father's business, to cage dive with great white sharks in South Africa, to have a family, to read every book on my to-read bucket list that just keeps getting longer, and so many more things. When I was 11, I stopped dreaming whenever I finally began to understand what trigeminal, glossopharyngeal, and geniculate neuralgia meant to me. This pain that we all experienced took the reality of dreaming away from me simply because I could no longer comprehend a world where I could check things off of a bucket list. On my good days, I would let my mind wander to a million different crazy life scenarios that I wanted to have, and in a zap, all those images would be clouded in gray. I spent far too long in this in-between state, and even longer not allowing myself to have a childhood. We used to say that whenever I was in pain, nonstop, every day, all day, that our home and our lives were shrouded in a dark cloud. And every time the pain returned, so did that dark cloud. My little sister Maya demonstrated hope for me every day, just in the way that she lived her life. But witnessing her life wasn't enough for me. My parents reminded me every single day to dream and to hope, but their constant reminders weren't enough either. It's whenever I was finally able to couple Maya's life and my parents' love together and to see my own self-worth that my pain experience fundamentally changed. See, for me, that was the thing about having a childlike hope. It creeps its way into every facet of your life. The way you smile, the way you walk, the way you talk, the way you feel, and for me, even the way I felt about my diagnosis. I should never have let those 4 words, trigeminal, geniculate, glossopharyngeal neuralgia, to allow me to stop dreaming. Seeing my self-worth changed the way I dreamed. I dreamed now about sitting through an entire high school class, about playing catch with my family, about finally straightening my hair, and for sleeping through an entire night. Whenever I realized that dreaming didn't have to mean cage diving with great white sharks, I began to let hope return to my life. Because you see, it doesn't matter how quote unquote small your dream is, it's empowering whenever you see that dream come to fruition. So I started to make a realistic bucket list, a place where I could add any and all things that I knew I was capable of completing. And that was empowering for me. And with each realized dream and every check off of my bucket list, I became happier and happier, and I finally allowed myself to dream bigger. And now my realistic bucket list includes cage diving with great white sharks. Hope empowered me to ask more questions and to seek out more answers. It empowered me to speak up and to use my voice. As a patient, your voice is the most powerful weapon you have. If my voice conveyed hope, I found that more people were willing to listen to me because I had the attention of the room. I commanded it. I commanded that those around me also hoped. I commanded the people around me to want to help me. My family, my doctors, my friends, my teachers, my coaches. For me, advocacy means the willingness to accept the situation you're in and then to fight for hope to rise above that situation. When I didn't hope and I didn't dream, I was angry and every word I spoke had fire behind it. That left my ability to advocate for myself in shambles. No one wanted to hear what I had to say because I blamed them for what I was going through. And I know now that wasn't fair of me, but that was a reality that my family lived in for so long. My inability to advocate for myself left others to make decisions for me. Now I know my family did everything and then some in their power to take away my pain, but there's no substitute for my own words. My words became powerful whenever I finally let hope creep back into my life. For Christmas in 2013, I asked my parents for brain surgery. I told them why I wanted it, why I was ready, and why they should trust me to make this decision. And then in March in 2014, I had microvascular decompression surgery with Dr. Mark Linsky. I know MVD isn't the right option for everyone, but for me it was, and I got my life back. After years of listening to doctors tell me my options and trying everything that was under the sun to try to alleviate my pain, I knew what I needed, because after all, I know my body best. I advocated for the surgery option because I wanted my treatment to be my decision, not anyone else's. I thought that living with neuralgias as a young patient meant I didn't have a say, but in reality, it just meant that I had to find my voice like everyone else. I joined the Young Patients Committee when I was 16 because I wanted to make sure that trigeminal neuralgia and geniculate neuralgia and glossopharyngeal neuralgia never left my life. I never want to forget what it's like to have a hope-filled dream come to fruition. I never want to forget the first time I met someone who understood the pain that I was going through. But most importantly, I don't want anyone to have to spend far too long in the back and forth state of hope and hopelessness. My neuralgias can be part of my story, but I will not let them be the story. And I don't want them to be anyone else's either. I'm not asking anyone to look at life with rainbows all the time because that's not accurate and that's not truthful. But I do ask that you look at your accomplishments, no matter how small, and realize that you made them happen. Whether it was getting married or getting out of bed, going to the grocery store, or going on a girls' trip, you were the one that made all those things happen. And there's something very powerful about looking our pain in the face and saying, no, not today. So whether you just graduated from school, joined an adult softball league, or finished a book, I hope you all add something to your realistic bucket list today. I'm going to finish yet another puzzle to mine tonight because during quarantine, that's been the obsession that I have. At the conclusion of this conference, I'm going to be posting on the Young Patients Committee Facebook page, asking what you all are adding to your realistic bucket list. And I really would love to hear your answers. So let's take the power and the hope back from our pain. Thank you guys for allowing me the chance to talk with you today. I wish we could all be together, but for now, a Facebook comment section about our dreams will have to do. And with that, I will turn it back over to Allison.
Go ahead, Allison.
Thank you so much, Kenzie. What a wonderful presentation to end the day. Is Dr. Brown able to join us as well? We just wanted to wrap up real quickly. We want to make a few announcements and say thank you. First of all, thank you so much to Kinley, who put on this production today. They have been wonderful and awesome, and we're so grateful to them. Dr. Brown, I'm going to shoot it over to you, and then I'll make a couple of closing remarks.
So I want to thank all the speakers. The fact that they were able to take a Saturday of their busy lives is an important thing, and I hope it was a help for you. This is not a graduate student seminar, and I don't expect all of you to memorize all the facts, but it's in here, the book. We're hyping the book. Go back and reread it. What if 500 people press a button and buy it? That would be quite an affair. And if you don't, we're going to start putting on webinars sequentially to go through these chapters and open them for discussion over the course of the next many months and give you an opportunity to learn more. There's always more to learn. There's always more for me to learn. And I hope in the future I learn that each of you has found peace without pain. Thank you.
Thank you so much, Dr. Brown. And I want to thank Allie and Anne for being your moderators today, to Danny and Tiago and our board, our committee, all of our wonderful volunteers who have helped to promote, to create this event. I want to thank all of you for joining us today. Please remember to help us to make an even better conference next time by taking the survey tomorrow morning. That will also enter you for a chance to win one of 5 copies of our new book. And I hope everyone has a very safe, healthy, happy end to 2020 and a safe, healthy, happy 2021 as well. Good night.